Thank you. I'd like to go ahead and call to order the Senate Committee on Health and Human Services for Tuesday, March 30th at 3:42 p.m. I apologize to everybody for the delay. Go ahead and start with a roll call and note that myself, Senators Kieckhofer, Hardy, and Harris are here. Senator Spearman, are you here? Okay, do not see Senator Spearman, so we will mark Senator Spearman present as she arrives. Thank you, everybody, for joining us today in Health and Human Services. I think we're moving along in this session, but just in case there's anybody new, just a reminder that there are many ways to participate in our virtual legislative session. If you are interested, please Google the Nevada Legislature, look for the NELIS, Art, N-E-L-I-S, and look for a help tab at the top of every page. You can email your testimony, you can call in to testify on public support, you can use the opinion polls. Please join us and engage in the legislative process. Today we have a very full agenda in Senate Health and Human Services. We will be hearing 5 bills. Those bills are Senate Bills 305, 309, 318, 329, and 340. What I can say for sure is that we're going to start with Senate Bill 318 and that we are going to end with Senate Bill 329. The middle may kind of depend on the comings and goings of some of our other members. So with that, I would like to invite Senator Doñate to the virtual dais, and I will open up the hearing on Senate Bill 305.
Thank you so much, Chair Ratty, and good afternoon to the members of the Senate Committee on Health and Human Services. For the record, my name is Fabian Doñate, and I represent Senate District 10 in the heart of Las Vegas. I come before you all today to speak on Senate Bill 318, which makes various improvements to language access in services provided by our governmental agencies. I want to start off this hearing by mentioning that I am the proud son of immigrants, and I always find myself in between the intersection of my Mexican ancestry and my American roots. When I was appointed to the Senate seat, I mentioned that my inclination to public health started off from my journey translating for my father under various settings. Nearly every child of immigrants can relate to the experience of having to translate for their relatives, whether it's a voter registration form, a field trip permission slip, or even the health literacy sheet at your local health clinic. Some would say it's a rite of passage that's easily recognizable across many households. This observed practice of having young children translate for their parents or grandparents is a policy shortcoming in our society, and it's something that needs to be addressed immediately with the health disparities that have been exacerbated under the COVID-19 pandemic. Today's conversation on language access is something that is long overdue, and I'm glad that we can have the opportunity to address a much needed gap that is always ignored until it is too late. COVID-19 has shown to us just how valuable information access can be for those who may not have the adequate education or resources to understand and take apart relevant health information. Failing to prioritize information access can result in public health disinformation and distrust, which is in direct alignment to an environment that could easily foster vaccine hesitancy. Vaccine hesitancy, as in the refusal of vaccines despite the availability of these services, is a very real problem here in Nevada that will become apparent within the next few weeks, especially as we begin to expand our reach to marginalized groups that have been abused and neglected for years. For me, I still find myself having trouble advocating and describing the technology of the vaccine to my own family members, despite having 2 public health degrees in this field. Add the layer of translating health information into a different language, and it becomes even more complex. In public health, we utilize the term health literacy to describe a person's ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others around them. Health literacy is an important thing to consider in developing programs that improve the community's health status, mostly because it acknowledges any present limitations and emphasizes the ability to use health information, not just to simply understand it. To make well-informed decisions, health literacy skills are needed. This means that the wide range of our population must have the adequate foundational knowledge of a health problem before even considering the implications that may arise. For instance, a clear example of health literacy skills being utilized during the COVID-19 is the practice of hand washing. Many employees understand the requirement of hand washing, but certain individuals with a lack of educational attainment might not have the background to understand why antimicrobial soap and heat can deter from cross-contamination and the spread of disease. Learning disabilities, cognitive decline, language fluency, reading abilities, all of these are factors that can impact how you absorb health information and translate this into better healthcare outcomes. And unfortunately, as we have clearly seen under this pandemic, individuals with poor health literacy are linked to a higher risk of death, ER visits, and hospitalizations. As legislators and public servants, the reality of this pandemic is that we have acted in defense, and that is why we have not done our best with how this response has taken shape. If we want to fix the disparities observed in our communities of color, we have to take the right step to invest in public health services that will achieve justice. The biggest takeaway from today is that health literacy starts at the distribution of information, and information is accessible when it is done in a culturally competent manner within your own native language. Your language is your culture, and your culture can modulate your perceptions of what health can mean to you. With the permission of the chair, I would like to invite Ms. Olivia Whiteley, the Western States Advocacy Officer from the Refugee Advocacy Lab, to give her remarks on the bill language, the proposed amendment changes, and a brief rundown on the intended outcomes of SB 318.
Senator Doñate, thank you for your introductory remarks, and we are looking forward to hearing from Ms. Whiteley, but I need to correct an error that I made. While I invited Senator Doñate up to present, I think I said I was opening the hearing on SB 305, which was an error because this is SB 318. So to avoid confusing the public, I just want to make very clear that we are hearing, that the hearing is open on SB 318, and that is the bill that we are currently discussing. And I promise if you're here for SB 305, we will get to that today as well. Thank you.
Perfect. Thank you, Chair and members of the committee, for hearing SB 318 and allowing me the opportunity to speak to this critical proposal. As the Senator mentioned, my name is Olivia Whiteley, and I am the Western States Advocacy Officer for the Refugee Advocacy Lab. Over the past several months, I've surveyed Nevada's resettlement agencies. The number one shared concern of these agencies is language access, particularly for refugees that speak uncommon languages. Organizations that serve Nevada's refugees report that qualified interpretation and translation services are often unavailable as clients interact with essential state agencies and programs, such as small business support or the DMV. These barriers have been amplified with the onset of the pandemic, as reliable, up-to-date public health information regarding the coronavirus is continually needed to enable refugee and limited English proficient Nevadans to protect themselves and their families. SB 318 is a response to these concerns and intended to address three critical needs. First, protecting Nevadans from the coronavirus. Second, protecting the civil rights of Nevadans. And third, protecting the state of Nevada. The bill was drafted based upon similar legislation previously introduced in other states, including Alaska, Pennsylvania, New York, Michigan, California, Hawaii, Washington, Illinois, New Jersey, Virginia, and New Mexico. Federal guidance regarding language access and feedback from local community groups. I will be speaking to the suggested amended version of SB 318, which is available to you on NELIS. The two key components of SB 318 as proposed in the amended text are first, COVID relief provisions. SB 318 requires the Division of Public and Behavioral Health in each health district or department to record the preferred language of every individual that receives COVID-19 services, provide limited English proficient individuals with interpretation services, either in person or remote, translate vital documents such as applications or notices related to COVID-19, translate any governmental order related to COVID-19 in a timely fashion, and collaborate with community-based organizations to ensure all local languages are represented. The requirements for language services are proportionate to the number and language of limited English proficient individuals served by the division or department, ensuring smaller health departments do not have to provide services in the same frequency or breadth as larger health districts. Further, SB 318 sets a general standard for agencies, requiring them to take reasonable steps to provide meaningful and timely access to vital information. This standard aligns with federal requirements and responds to health district requests that capacity be considered in SB 318's language. Finally, it is intended that this section be funded by federal coronavirus relief funds. Second, SB 318 requires state agencies to create language access plans and submit them to the legislature during the following biennium. SB 318 does not require agencies to implement their language access plan, only to develop and revise the plan, allowing the legislature to consider the full funding required for implementation in 2023. The plan includes a survey of existing language access needs, services, trainings, and certification schemes, and considers literacy, digital access, and cultural competency. The proposed amendment requires a public comment period for the drafted language access plans to ensure the voices of interpreters, translators, and LE clients are adequately taken into consideration. The first component primarily addresses the first need, protecting Nevadans from the coronavirus. The health of one Nevadan impacts the health of all Nevadans. Ensuring limited English proficient Nevadans and their families have access to COVID services protects the health of English proficient Nevadans and their families. Many Nevadans require interpreted or translated information regarding social distancing and masking recommendations, transmission severity, testing and vaccination options and processes, contact tracing procedures, and local laws and regulations. According to data from the 2019 American Community Survey, between 10.7% and 13.8% of Nevada's adults and 5.8% of Nevada's children speak English less than very well. Proficiency varies based on language group. For example, 40% of Nevada's Spanish speakers speak English less than very well, while 20% of Nevada's French speakers speak English less than very well. There has been a 75% increase in Nevada's limited English proficient population from 2000 to 2019, and Nevada's population continues to increase in linguistic diversity. The Gwynn Center's September 2020 report, The Impact of COVID-19 on Communities of Color in Nevada, describes the higher infection, hospitalization, and mortality rate for Nevadans of color. The report ascribes these disparities to limited access to healthcare, including linguistic barriers in patient-provider communication. Linguistic barriers inhibit health literacy. SB 318, through both its COVID and language access plan provision, provides all agencies, but particularly the Division of Public and Behavioral Health and local district health divisions or departments, to support Nevadans in understanding information on how to manage common health conditions that are COVID-19 risk factors, such as diabetes, heart disease, or lung disease, access COVID preventative care, such as testing or contact tracing, comply with public health recommendations, such as social distancing or double masking, or discuss their concerns regarding vaccination. In addition to assisting Nevadans in overcoming informational barriers, SB 318 assists Nevadans in navigating procedural barriers, such as finding a location to receive a vaccine or reporting their prior contracts to a contact tracer. Language access is a prerequisite to Nevada's coronavirus response. Without language access resources, Nevada's most impacted communities will face significant challenges in accessing basic COVID information and care, particularly regarding vaccination efficacy and availability. Which brings me to the second need, protecting the civil rights of Nevadans. Section 601 of Title VI of the Civil Rights Act of 1964 reads, "No person in the United States shall on the ground of race, color, or national origin be excluded from participation in, be denied the benefit of, or be subjected to discrimination under any program or activity receiving federal financial assistance." The 1974 Supreme Court case Lau v. Nichols interprets the Civil Rights Act's prohibition of discrimination on the grounds of national origin to include protections for individuals with limited English proficiency. Both deliberations regarding the Civil Rights Act and the Lau v. Nichols decision highlighted the foundational inequity of individuals paying taxes and being unable to access the programs and services those dollars funded. Justice William O. Douglas quotes the congressional record in his Lau v. Nichols decision. "Simple justice requires that public funds to which all taxpayers of all races contribute not be spent in any fashion which encourages, entrenches, subsidizes, or results in racial discrimination. To ensure limited English proficient Nevadans can access the services they subsidize, Nevada should invest in additional language access services, both with its COVID response efforts and across agencies' day-to-day activities." This sentiment is actualized in relation to federal funds. In the year 2000, President Bill Clinton signed Executive Order 13166, improving access to services for persons with limited English proficiency, directing federally conducted and federally assisted programs and activities to be made accessible to otherwise eligible persons who are not proficient in the English language. SB 318 sets a similar standard as Executive Order 13166 and other areas of federal code. The proposed amendment of SB 318 reads, "All state-conducted and assisted programs are obligated to take reasonable steps to provide meaningful and timely access to eligible individuals who are limited English proficient." Additionally, much of the content of SB 318 is drawn from guidance regarding Executive Order 13166, issued by the U.S. Department of Justice Civil Rights Division in May 2011. The document provided to you on NELIS, entitled Language Access Assessment and Planning Tool for Federally Conducted and Federally Assisted Programs. The guidance suggests all federally conducted and assisted programs and activities, 1, assess the number or proportion of LEP persons from each language group in its service area to determine appropriate language assistance services, as recommended in sections 2, 3, 4, and 7 of SB 318, and 2, creates language access policy directives, implementation plans, and procedures. SB 318 acts as a statewide policy directive, and Section 7 of the bill recommends agencies create implementation plans, assuming agency-specific procedures will naturally follow. The guidance also recommends that agencies appoint a language access coordinator, again, as recommended in Section 7 of the bill. I would encourage you to conceptualize SB 318 as a codified pathway to compliance with existing federal civil rights law, not an additional mandate, as the federal mandate for these types of activities already exists. SB 318's requirement for the drafting of language access plans is the smallest possible ask the state of Nevada could make in an effort to expand language access. As mentioned previously, the proposed amended bill text only requires agencies to draft the plan over a 2-year period, with implementation costs slated for examination during the 2023 session. Which brings me to the third critical need that SB 318 addresses: protecting the state of Nevada. SB 318 provides the state of Nevada with locally adaptable tools necessary to ensure statewide compliance with federal civil rights guidance. Currently, there is no state-level standardized process for ensuring state agencies take reasonable steps to ensure meaningful access to eligible, limited English proficient individuals. There is no statewide requirement in Nevada revised statute, nor is there mention of linguistic accessibility in the 2020 statewide administrative manual. In the exhibits on NELIS, you will find a small packet entitled Nevada Health and Human Services Language Access Policies. According to the 2011 guidance from the Department of Justice, policy directives should be made publicly available. This packet includes the publicly available language access policies for each division of HHS. The 2011 guidance notes policy directives should set forth standards, operating principles, and guidelines that govern the delivery of language-appropriate services and are distinct from the more detailed managerial language access plans required by SB 318. Within HHS, the Division of Child and Family Services has the most comprehensive set of publicly available language access policies, an LEP policy from 2017 and a culturally and linguistically appropriate services policy from 2018, found on pages 1 and 6 of the PDF. These policies contain the components that SB 318 would require of all agencies: a commitment that agencies will take reasonable steps to ensure meaningful access, a survey of existing regulations, a requirement that staff identify and document a client's preferred language in their DCFS medical record, a broader linguistic needs assessment of the client population, a description of vital documents, discussions of trainings, a provision to provide a notice of availability of language services, and a stipulation to review the language access policy. These policies also reference resources for staff, including I Speak cards to assist staff in the identification of client languages, lists of contracted and staff interpreters, and appropriate client consent and privacy forms. These two policies are the most well-developed policies of any HHS division. However, even these policies are 4 to 5 years old and lack standardization. For example, the culturally and linguistically appropriate services policy defines an interpreter or translator as an individual who has a bachelor's degree from an accredited institution, preferably in languages or linguistics, and possesses at least 1 year of specialized experience, while the LEP policy has no such definition or qualifications requirement. As both policies are specific to the same program area within DCFS, children's mental health, this fundamental determination of who is competent to interpret or translate treatment options, eligibility requirements, or medical conditions to parents whose children are facing mental health difficulties should be standardized. If you flip through the policies of other HHS divisions, you will see a further lack of standardization. Some policies are a single paragraph, some policies are not publicly available. The agency or division an individual is dealing with should not determine an individual's ability to access essential information in their preferred language about programs that they are eligible for and are funded by their tax dollars, nor should an individual's zip code. It is possible and likely that the agency and its divisions have additional policies, plans, and resources for ensuring language access that are not readily available to the public or otherwise included in this PDF. Further, this is not intended as a comprehensive evaluation of the existing language access work of these departments. All HHS agencies and divisions will be strong partners in implementing SB 318 if passed and has expertise necessary for successful execution. The individuals within these agencies we have spoken with regarding SB 318 articulated a strong desire to expand their language access offerings, but a general lack of resources to do so. Regardless, the disparities in readily identifiable public policies make a compelling case for SB 318's statewide standards and instructions to assist agencies and their divisions in successfully working towards linguistic accessibilities. State and local agencies and health systems have seen consequences for failing to provide adequate language access services. There is a process by which individuals can file complaints that have led to investigations by the Department of Justice or other agency Office of Civil Rights. Notably, the Pennsylvania Department of Human Services, which was investigated in 2019 after one advocacy group and 2 Spanish speakers reported that they did not receive adequate or timely language support. The Alabama Department of Human Resources in 2017 after one complaint from a Nacteco speaker, which is a Mayan language. The Erie County of New York's Department of Social Services in 2016 after 5 individuals provided complaints, and a California hospital in 2014 after 3 complaints from individuals who speak an indigenous Mexican language. These investigations typically result in an institution entering into a voluntary resolution agreement, or VRA, which most frequently requires the institution to take specific steps to improve LEP access. SB 318 preemptively requires agencies to take these steps. For example, you can see some highlighted stipulations of the 2019 VRA between the Health and Human Services Office of Civil Rights and the Pennsylvania Department of Human Services listed on this slide. They are the same recommendations as included in SB 318. In addition to responding to a wide range of language access needs, the DOJ interprets Title VI to apply to a wide range of programs and activities. According to the Department of Justice, quote, Title VI covers a recipient's entire program or activity. This means all parts of a recipient's operations are covered. This is true even if only one part of the recipient receives the federal assistance, end quote. SB 318 establishes a statewide policy directive and provides agencies with guidance and an opportunity to discuss the resources necessary to comply. Beyond providing protections to the state of Nevada, SB 318 is the right thing to do and demonstrates Nevada's commitment to racial and linguistic equity. Thus, I would encourage committee members to support SB 318, and I am now available for any questions. Thank you so much.
Thank you. Senator Doñate, any additional parts of your presentation?
I think we're ready for questions if any of the committee members do.
Okay, opening it to the committee. Anybody have questions?
Madam Chair.
Senator Keycupper?
So, yeah, thank you, Senator. So the requirements in the bill are for any and all languages, right? There's no thresholds in like top 10 most common spoken, or I'm wondering about the workload of getting all of this done for state agencies, and especially if we're targeting the first few sections to the pandemic and emergency declarations and things like that. I'm just trying to figure out the scope of the ask, because I don't happen to know how many total languages are spoken in the state of Nevada, but I'm sure it's more than a few.
Thank you so much for that, Senator Keycupper. Senator Donate, for the record, I think my main intention with this bill, and I'll like Olivia to speak further on this, is that it's whatever is reasonable to help us navigate this pandemic. As you know, there are many different languages around the world, and there are many languages that are spoken within this state. And my worry when we were drafting this bill is that as we start to vaccinate more and more people, it's going to be harder and harder to reach those who do not want to be vaccinated, or who are like on the verge of trying to decide whether or not this is a decision they want to make. And for us to provide accurate information to those individuals, we have to do it in a manner that respects their native language. But I'll let Ms. Olivia Whiteley speak further on that.
Yeah, thank you, Senator Donate. This is Olivia Whiteley for the record. First, I'll say that any requirement that an agency determines they have to serve an LEP individual is proportionate to the languages that are spoken with the clients that they serve. So that determination first begins with the agencies gathering data. either through the COVID provision or through the language access plan provision on what the languages are of the individuals they serve. So there's not a blanket mandate that all agencies have to serve all languages. It's dependent on the needs of the clients of each individual agency. The second thing I'll state is that the amended version that is suggested and posted on Nellis sets the standard to be that an agency has to take reasonable steps to ensure meaningful access. And that is a flexible standard that an agency has to follow, and is also consistent with what is required in federal law. The third thing I'll say is that the COVID provisions are dependent upon appropriation of federal funds. So I would imagine that the reasonable steps an agency would take in terms of the COVID provision would also be dependent on what federal funding is allocated for these particular activities. And similarly, that will also be true with the language access plan provisions, which the implementation questions of those plans and policies will not be discussed until the 2023 legislative session.
I'm sorry, I appreciate it. Thank you very much for that, Ms. Whiteley. I'm trying to work through the amended language on the fly, and I apologize for not being fully prepared. So Section 8 kicks in 2 years after the termination of the governor's emergency. Is that right?
I could speak to this. This is Olivia Whiteley for the record. Section 8 only removes the requirement that revisions of agency language access plans must include an evaluation of how the agency addressed language access needs during COVID-19. So it just changes what's included. Sorry, go ahead.
I'm sorry. So for the first 2 years following the governor's termination of his declaration of emergency, the agencies are required to do a retrospective look at how they performed during COVID, during the pandemic. Am I hearing that right?
Olivia Whiteley for the record. That's correct.
Okay, thank you.
Thank you. Any additional questions from the committee? Senator Hardy. And then I'm going to need to step out for a minute, so Senator Spearman is going to take over.
Thank you, Madam Chair. So when it references the division, but the bill basically says this is an unfunded mandate on the local governments, not the state. And so the local governments are going to be held accountable for this. So which division is this? The Board of which division is it that we're looking at? The Health District of Clark County? Is that the only division?
I'm happy to answer this, Senator Dunyate, if that's all right with you. This is Olivia Whiteley for the record. So Section 2 requires the Division of Public and Behavioral Health to implement the COVID-related provisions. Section 3 and 4 require local health districts or departments to implement those provisions. I will say in response to the note that this is unfunded mandate, that if you look to the suggested amendments, they do include lines for both sections 3 and 4 that this section shall be implemented to the extent that funding is made available, with the intent that those only become operative if monies from the American Rescue Plan are allocated for these purposes.
So, so it does include the state as well as the health district of the largest county.
Yes, yes.
Thank you.
Vice Chair Spearman, I have a follow-up question, if you'd be willing.
I'm on mute. Yes, sir.
Thank you. I appreciate it. Senator, at the top of the proposed amendment, It's listed under additional provision. It's not really incorporated into one of the sections of the bill. So I'm trying to figure out the intent of that. With the definition of state assisted program, meaning all programs that receive state funding, that is an awful lot, right? That's brand inspectors for ag, that's, it runs the gamut, right? So is this supposed to be specifically related to public health, or are we talking everything that the state does?
Thank you, Senator Kekeffer. So, Senator Donate, for the record. So, my intent of this bill is divided into two parts. The first part is COVID-19 oriented, and then the second part is to revise the services that we provide as a state and any needs and gaps. To look at those gaps, see what we can improve, and then in the future session, to use these 2 years as our time that we can identify what those gaps are, and then in a future session, if we think that those requests are warranted, we can make the allocations to solve those disparities. And I can let Ms. Olivia Whiteley speak more to that.
Thank you, Senator. This is Olivia Whiteley for the record. The intent of that additional general provision is actually to provide local districts additional flexibility in the implementation of the COVID provisions, and also agencies a little bit of flexibility in the implementation of the language access plan provisions. So the standard to make a reasonable effort or to take reasonable steps to provide meaningful access is the standard that we're looking towards in order to allow agencies that flexibility. In terms of the definitions of state assisted programming, that is modeled after the existing federal requirement that any federally conducted or federally assisted programs are required to assure language access from any subcontractors or grantees. But I believe the senator is open to discussion for further amending the bill if that's a significant concern of yours.
Thank you for that. So to be clear, in the top of the amendment where it says additional provision, that's just the language that you've inserted into the different sections. You're not expecting a standalone. Does that stand alone as a piece of statute? I'm just trying to figure where it fits into the bill.
This is Olivia Whiteley for the record. It's drafted to do both. So first be an additional general standard that is set up for the agencies, both in terms of the language access plan and COVID provisions, and it's also integrated throughout the language of the bill.
Senator Kekeffer, was your question answered?
Madam Vice Chair.
Yes, thank you, Madam Vice Chair. Appreciate it.
Okay, righty. Any additional? I see Senator Hardy. Yes, sir.
Thank you, Madam Vice Chair. So along Senator Kekeffer's questions, basically, to his point, all state agencies that receive state funding, schools, everything that gets money from the state, this will apply to. Schools, etc., everything, right?
Thank you, Senator. This is Olivia Whiteley for the record. So the COVID provisions will only apply to the Department of Public and Behavioral Health and the local county health districts or departments. The requirement to draft, not to implement, but to draft a plan, a language access plan, will apply to all state agencies.
So can you delineate which sections are COVID and which sections are not COVID?
Yes, Senator. Again, Olivia Whiteley for the record. Sections 2, 3, and 4 are COVID related, and Section 7 is related to the language access plan drafting requirement.
And so the state assisted programs are just the COVID 2, 3, and 4 sections?
I believe the state assisted requirement would fall under Section 7, which requires agencies to develop a language access plan.
Okay, so that sentence belongs to Section 7, that state-assisted programs.
I believe so, Senator.
Thank you.
Additional questions?
Vice Chair, can I jump in one more time? I apologize.
Yes, sir.
Thank you. Ms. Wiley, can you point me to like an example of a state that has a really good language access plan that I can get my mind around what we're going to ask every agency to do?
I can point you to states that have introduced similar legislation, and then I can point you to DCFS is example of 2 language access policies that we think would meet or is in the direction of meeting the standards that this bill outlines.
So the
Go ahead.
example up on Nellis from DHHS is what you're thinking about?
On pages 1 and 6 of that PDF are the 2 policies from DCFS that we think are the most well-developed and in the direction of what we would like to see through this piece of legislation. Yes.
Okay, I will look at them. Thank you.
Keffer? Was that the end? Okay. All righty. I see our chair has returned. I can return the metaphorical gavel to you, or we can keep going.
Happy to jump back in.
Okay.
So committee, do we have any additional questions? All right. Not seeing any, we're going to go ahead and open it up to the public. So right now we would like to have anybody who would like to testify in support. Again, that is testifying in support of SB 318.
Thank you, Chair. Callers, if you'd like to testify in support of Senate Bill 318, please press *9 now to enter the queue. Will the caller with the last 3 digits of 565 please slowly state and spell your name for the record? You may begin now.
Hello, can you hear me okay?
Yes, we can.
Yes, we can.
Perfect. Good afternoon, Madam Chair, members of the committee. My name is Manuel Mederos, and I'm the Language Access Specialist for the Northern Nevada International Center in Reno, Nevada. I run a program called the Language Bank. I'm giving testimony in full support of SB 318 because it's critical that each Nevada state agency is able to create their own language access plan. This plan would help state agencies meet their language needs, and Nevadans experiencing significant barriers to accessing state services related to COVID-19 due to the lack of materials and information translated. The COVID-19 pandemic has disrupted nearly every aspect of our lives and has reached into nearly every community in our state. Our ability to keep one another safe and healthy depends on every Nevadan having access to a credible, trusted information about how to prevent the spread of COVID-19, the types of supports and services available, and how to comply with federal, state, and local orders. We know certain communities are disproportionately impacted by this pandemic, and one way we can shift that and adjust it is by meeting our obligations to communicate in ways that are accessible and culturally and linguistically relevant. The Northern Nevada International Center Language Bank provides 20 languages in person, 200 languages over the phone, and over 15 languages, including American Sign Language, over video remote interpreting technology, documentation, translations in over 100 languages. All these languages services is just one example of resources that our state needs to stay culturally relevant. Many state agencies do not have access to the diverse services that the Language and Bank provides. Only statewide planning and resources can expand language access for all residents equitably. Lastly, COVID-19 took the life of my father, my 87-year-old father, just a few months ago. And I know many of you have family members or know of someone that has greatly been impacted by this horrible chapter in our lives. My father was hospitalized twice during this struggle with COVID-19. I recall my father calling me often from the hospital, asking me to interpret for him because all nurses and doctors did not understand him and were not able to communicate with him in his own language. Imagine you being in the hospital and having no family allowed to come to see you, and to top it off, have care providers that are not able to communicate with you and hold your hand to tell you that you're loved and that your life matters. We need SB 318 to ensure that all our underserved communities can access life-saving information and care. I really thank the committee for hearing me today. Thank you so much for this opportunity.
Thank you for spending your afternoon with us, and I'm so sorry for your loss.
Thank you.
Will the next caller with the last three digits of 425 please slowly state and spell your name for the record? You may begin now.
My name is Deborah Silvera, DEBORAH Silvera. Good afternoon, Madam Chair and members of the committee. My name is Deborah Silvera, and I'm from Las Vegas, and I am here on behalf of NETA, the Nevada Interpreters and Translators Association, and we fully support SB 318 because as language access professionals, we are intimately aware of the needs for Nevadans with limited English proficiency or LEPs to have access to all information regarding government services. This must include access to trained and qualified interpretation and translation services, which are necessary for Nevadans to receive accurate, vital information regarding government services. The use of machine translation aids, such as Google Translate, can lead to unwanted errors in conveying the original message. This can range from the simply comical to dangerous, serious miscommunications. Likewise, the use of untrained bilingual persons to interpret, such as family members, often minor children, is not only dangerous, but it's also ethically unsound. SB 318 supports this objective by requiring agencies to outline adequate credentialing and oversight of translators and additional requirements, trainings, incentives, and recruiting initiatives to support interpreters and translators. Trained and qualified language access services are even more critical during the COVID-19 crisis, where a lack of accurate information can not only lead to unwanted individual health consequences, but can also have a catastrophic effect on the community at large. All aspects of the public health effort to deal with COVID-19 require an informed public that this ranges from testing to masking to efforts to immunizations to contact tracing. SB 318's requirements for additional COVID language resources will help not only assure that all Nevadans receive accurate information about COVID-19, but it also will build trust between a populace that is often suspicious of public health agencies and that have suffered disproportionately from the effects of the pandemic. On behalf of NETA and myself, I thank you for your attention. And again, I repeat that we fully support 319. Thank you for your time.
Thank you.
Will the next caller with the last three digits of 186 please slowly state and spell your name for the record? You may begin now.
Hello, my name is Chloe Shaw, spelled C-H-L-O-E. Last name is H-S as in Sam, I-A. I'm the Civic Engagement Manager for the Asian Community Development Council. Thank you, Chair Eddy and committee members, and to Senator Donate for presenting this critical language access bill. We are a community organization that serves the fastest growing community in Nevada, providing the community with critical resources and services, including open enrollment navigators, our food bank, among others. We are in support of SB 318 because language access is a crucial part of our work, and we see personally the gap that exists in communicating critical public health information to the community. Last year during this time, we translated COVID-19 response materials in Tagalog, Chinese, Korean, Vietnamese, and Thai. There's a lot of misinformation on messaging sites, and providing expanded language access for everyone helps with health equity. Thank you for your time. We ask you to fully support SB 318. Thank you.
Will the next caller with the last three digits of 312 slowly state and spell your name for the record? You may begin now.
Good afternoon. My name is Bushra Dos Santos, first name Bushra, last name Dossantos. Madam Chair, members of the committee, thank you for having me. I serve as the Director of Refugee Resettlement at Catholic Charities of Southern Nevada, and I am representing our organization in support of SB 318. Catholic Charities of Southern Nevada is recognized as the state office for refugees. Through this program, we resettle hundreds of refugees each year from around the world who have fled their homes due to war and persecution. In 2020, we served over 1,200 refugee clients. Our clients speak many languages, including Arabic, Farsi, Dari, Swahili, Kinyarwanda, Kinyamulenge, and others. Although our office provides robust services and adequate interpretation to our refugee clients, SB 318 is vital in ensuring that all refugees and limited English proficient individuals can access essential services across all government agencies. The COVID-19 pandemic has amplified many challenges our refugees have in accessing these essential services. With a lack of adequate interpretation and limited office availability of government services due to the pandemic, our refugees have struggled with the following: filing unemployment claims after being laid off, obtaining Social Security cards, and applying for public assistance, amongst many others. In addition to these, the lack of COVID-19 information available in the languages that our refugee clients speak make it hard for them to have equitable access to the same information that their English-speaking counterparts have, thus barring them from accessing appropriate care. Only statewide planning and resources are necessary to enhance language access for not only our refugee clients, but all residents equitably. Passing SB 318 is the first step in the process of identifying where the gaps in language services are and how best they can be addressed to meet the growing needs of our population that becomes increasingly diverse. Catholic Charities of Southern Nevada supports this bill, and we hope that the members of the committee will do so as well. Thank you for your time.
Thank you. And BPS, moving forward, I want to make sure that we are limiting public testimony to 2 minutes per individual today. We've got 5 bills to hear, and we're getting some really wonderful public testimony, but I want to make sure that everybody has time.
Certainly, Chair. Callers, we are on testimony in support of Senate Bill 318. If you would like to give testimony in support and have not yet entered the queue, please press *9 now to do so. Will the next caller with the last 3 digits of 261 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Good afternoon. Thank you, Chair Ratty and members of the committee. My name is Jillian Block. That's GILLIANBLOCK. And I am speaking in support of Senate Bill 318 today on behalf of the Nevada Coalition of Legal Service Providers. The legal aid providers in the state frequently serve people with limited English proficiency, and generally, identifying and addressing language access gaps is extremely important. And with respect to the COVID-19 pandemic, unfortunately, the language barriers that already exist have become even steeper since the onset of the pandemic, and COVID-19 has made clear many areas where language access is critical. The health information necessary for people to keep themselves and their families safe and to prevent community spread has been rapidly evolving, and all Nevadans, regardless of language or national origin, should be able to learn about and access this information and the vital services that they're eligible for, and to learn about the vital services they're eligible for. Improving language access for people seeking health information, understanding public health recommendations, accessing testing, treatment, and vaccine information is extremely important, and we support SB 318. Thank you.
All right, if there are any more callers who wish to testify in support of Senate Bill 318, please press *9 now to enter the queue. Chair, at this time, no additional callers have indicated that they wish to testify in support of the bill.
Thank you. Let's go ahead to Testimony in opposition limited to 2 minutes per individual.
Thank you, Chair. Callers, if you'd like to testify in opposition to Senate Bill 318, please press *9 now to enter the queue. Once again, that is *9 now to enter the queue for opposition to Senate Bill 318. Chair, at this time, no callers have indicated that they wish to testify in opposition to the bill.
Thank you. Let's go to neutral testimony on SB 318.
Callers, if you'd like to testify in a neutral position for Senate Bill 318, please press *9 now to enter the queue. Will the caller with the last 3 digits of 200 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Good afternoon, Madam Chair, members of the committee. Bradley Mayer of Argentum Partners here today to testify neutral on SB 318 on behalf of the Southern Nevada Health District. We wanted to thank Ms. Whitley and Senator Donate for working with us on this bill. Senator Donate had reached out early. We had expressed some concerns with the way it was originally drafted, and he worked closely with us to develop some amendments. And so these proposed amendments that he's brought forth are more permissive and, of course, are contingent upon funding being available to execute these new responsibilities. And so we're just going to continue to work with him to ensure that the language of this amendment doesn't create an unfunded mandate should the funding fluctuate or not be permanent. And we thank you for your time.
Thank you.
Will the next caller with the last 3 digits of 672 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Good afternoon, Chair, Ratty, and Committee. For the record, my name is Joelle Gutman Dodson with the Washoe County Health District today. And in the interest of time, I just wanted to ditto exactly what Bradley Mayer said for the Southern Nevada Health District. We appreciate working with Senator Donate, and we look forward to working with him in the future with this bill. Thank you.
Thank you, and thank you for being brief.
If there are any more callers who wish to testify in a neutral position for SB 318, please press *9 now to enter the queue. Chair, at this time, no additional callers wish to testify in neutral for the bill.
Thank you. So I will go ahead and send it back to the sponsor. Do you have any closing comments?
Thank you so much, Chair Ratty, for the opportunity, and to the committee members for being able to speak with you all today. The closing remark that I just want to make is brief, since I know you guys have other bills, is that when I first started off in this journey in the Senate and I was trying to figure out what bills I wanted to push forward, I knew that language access and public health had to be one of those priorities for the sake of my family, for my district, and the greater immigrant community as a whole. SB 318 is a mandate that can address many of the observed gaps of translational services. It reframes the conversation that we've had in increasing access to the COVID-19 vaccine, and it provides leverage to Nevada families that have been ignored for far too long. So thank you again for your consideration.
Thank you, Senator, for bringing this bill. All right, I'm going to go ahead and close the hearing on SB 340. I'm sorry, I'm having a problem today. That would be SB 318. And then I'm going to open the hearing on SB 340 and ask Senator Neal to join us at the dais.
All right. Hello. Okay. I am Senator Dina Neal, and I am here to introduce SB 340. I have a couple of presenters that will be joining me. Ms. Grace Machtel, she's the Executive Director from SEIU 1107. Vanessa Torti, who is with SEIU, who will do the technical walkthrough through the bill. And we will have Marlene Locker to answer a few questions, and Farron Epstein, a home care worker, who will tell the personal experience. So I will just start off giving some really quick introductory remarks. When I was asked to carry this bill, I immediately said yes. The story of the home care worker is compelling. I had a direct story with a home care worker who took care of my father, and she was responsible for bathing him and placing him in his pajamas. I immediately was brought into a world where I understood the life of the sick and the elderly. We were in a different position than most when we contracted for services because of the pandemic. My daughter and I both work virtually. So we were not faced with having to be physically at work and manage the care of a loved one. But that is the reality for other families who do not have the capacity to work remotely. These workers matter because they become a part of a tiny society that forms when people exist under one roof. Our ingress and egress revolves around the sick, and it is important that they receive the proper training, transportation, reimbursement, and other things that are listed in the bill. My advocacy is triggered for this bill, SB 340, because taking care of the sick is something that you will never imagine until you have to experience it and walk it every day. And you have to then contract for the services for the individual that you need to have to come into your house that will simply allow you the 2 hours or 4 hours a day to free up time to go pick up a prescription or simply eat. Our focus was totally on one person. And in that focus, we found that in the time that we needed just to sit on the phone, call the doctor's office and schedule, that the 2 hours that we had contracted for a home care worker allowed us that free time to take care of other duties that they could not take care of. Our home care worker her role was to clean up, bathe my dad and put his pajamas on and get him ready before he passed away. And so I wanted to bring that clarity to this bill because the medicine reminders that people think about today where you say, oh my God, I forgot to take my vitamins or I forgot to take my pills. For a sick and elderly, you have to remain on a schedule for them and you cannot miss their pill schedule. It has to be consistent. And our home care worker was integral in helping us because that was one of her duties, was to remind us when we needed to take care of just simply the 7 pills that he had to take at 2 or at 7 or at midnight. And so I wanted to bring that perspective. And with that, I will go ahead and pass over to Ms. Machtel, who will discuss the need for this bill and the history. Thank you, Senator Radding.
Thank you for sharing your story, Senator.
Thank you, Senator O'Neill. Good afternoon, committee members. My name is Grace Vergara-Machtel, Executive Director of SEIU Local 1107. SEIU Local 1107 represents 19,000 healthcare and public sector workers across the state. I would like to thank Chairwoman Ratty and Vice Chairwoman Spearman for holding this hearing on the issue that is an urgent concern to all Nevadans. And again, thank you, Senator O'Neill, for your leadership in sponsoring Senate Bill 340. I cannot overstate the importance of this bill. Crisis in Nevada. Our state has one of the fastest growing senior and retirees population in the nation, driving and surging rapid demands for high quality home care services for our most vulnerable residents. The vast majority of funding for home care services in Nevada comes from taxpayer dollars flowing through the state's Medicaid program. We can all agree the COVID pandemic has proven just how critical home care services are in Nevada. In many cases, these services make it possible for our family members and neighbors to stay in their home instead of having to go to nursing homes. This saves the state money and has kept these vulnerable residents safe during COVID. Still, we have seen the rate of funding for home care actually get cut during this COVID crisis in Nevada. In fact, the current Medicaid reimbursement rate for personal care services is the lowest rate it's been since 2003. The lack of funding is the backdrop of the future challenges we face for home care in Nevada. National studies have shown that 1 out of every 2 home care workers leaves the field within a year. And in Nevada, the Green Center's September 2020 study on the personal care workers warns of a major care crisis on the horizon. Since 2010, the number of home care workers in Nevada has almost tripled. That sounds like we're heading into the right direction. But when you combine low pay and very few benefits to encourage new workers to join the field, along with a middle-aged home care worker population, Nevada could face a dangerous shortage of workers to provide critical home care services in the years ahead. Here are some key facts I'd like you to know about these frontline essential workers who risk their health and safety to take care of most vulnerable citizens during this pandemic. The state's 13,000 home care workers, known as personal care aides, earns a median hourly wage of $11.07 per hour. Well, let me repeat that. These workers who are risking their lives during this pandemic are earning a median wage of just $11.07. I've talked to many who are earning $10. That's below the national average for home care workers and far below what it actually costs to live in the greater Las Vegas area. Women of color make up 35.2% of the personal care aid workforce in our state. Nearly 1 in 5 of these workers, 19.9%, are uninsured. That's 8 percentage points higher than the Nevada's overall uninsurance rate of 11.9 in 2018. Just under 1/3 of personal care aides, 32.0%, in Nevada receive healthcare coverage through Medicaid. And as I mentioned earlier, but I want to repeat again, new workers are not coming or staying in the home care field, often citing low wages and lack of benefits. 1 in 2 home care workers will leave the job within the first year. Think about that for a minute. Half of these workers will leave home care. The home care industry in Nevada is incredibly splintered, with almost 300 personal care agencies licensed to provide home care services. These hundreds of agencies set varying labor standards. This means that training and safety standards are not consistently enforced. This could lead to dangerous situations for workers and consumers, especially in a time where a pandemic has highlighted the needs for additional safety protocols. Home care workers have risked their health and safety along that of their family and loved ones to do this work until the pandemic. But there haven't been enough procedure, training, or equipment to protect them or their clients during this deadly time. Too often, home care workers and their clients were left to fend for themselves. Many Nevada home care workers are forced to pay out of their own pockets for supplies, equipment, registrations, and training, or not receiving any training they need on a timely basis. Over the past year, some agencies provided no personal protective equipment, or as we know, PPE. Protecting the needs of our most vulnerable citizens and lowest paid workers will put our state's home healthcare industry in a dangerous position and jeopardize its future. That is why we need Senate Bill 340 to establish a home care workforce safety and standards board. Establishing this board would allow home care workers, consumers, and personal care agencies to be equal partners with state government agencies to set industry-wide standards that will improve home care for all Nevada stakeholders and ensure quality care is available for consumers for decades to come. We've seen how hard it is for agencies and workers to succeed in current environment, especially with this low rate of Medicaid reimbursement. And we know the negative impact the lack of qualified workers and enough hours to care can have on consumers and their families. The Home Care Safety and Standards Board will bring together everyone to depend on to provide these critical services in our state so we can find solutions together. SB 340 will improve home care standards and build stronger home care system in our state. One crucial way it will do that is by providing the workforce with a voice it lacks in the current system. For too long, home care workers have not had a seat on the table. SB 340 will ensure that their stories, their experiences, and their expertise will influence future policy decisions. This bill will ensure home care workers' voices are heard to provide three critical components. One, it will empower home care workers to join together to petition the state to investigate their working conditions. Second, it will require the state to make decisions about home care with more transparency and to be more accountable to the public. And third, it would allow the board to examine pressing issues such as Medicare reimbursement rates, wage staff, recruitment and retention rates for the home care workforce, and compliance by agencies with training and other relevant regulations for the home care industry. Let me say, I am honored to be here to add my voice in support of these workers and consumers. Many of us have known for a long time how essential home care workers are for our state. Now, I hope that during this deadly pandemic, we have all come to realize that 13,000 Nevada caregivers are heroes. They deserve our thanks, but even more than that, they deserve to be respected and they deserve to be paid a fair wage that can live on. And ultimately, workers, consumers, and the industry and our government must work together to fix the home care system and raise the standards to care and working conditions in Nevada. I'm convinced with Senate Bill 340, we can do just that. Thank you for your time. And now I'd like to introduce my colleague, Vanessa Totri, who will walk through the details of the bill.
Great, thank you, Grace. And presenters, I just do want to remind you that we do have 5 bills to hear today. So if you can be as on point and concise in that walkthrough, that would be great.
Hello, my name is Vanessa Torti. I am the Senior Home Care Coordinator for SEIU. My work over the past decade focuses on home care policy and how states structure their home care programs in states across the country. SB 340 would allow the state, under the direction of the Health and Human Services Director, to convene a home care employment standards board where home care workers, employers, consumers, and state officials would come together to investigate and come up with recommendations on topics like the adequacy of wages and Medicaid reimbursement rates, training standards, recruitment and retention levels, COVID safety protocols, and other worker protections. The HHS director has the discretion to implement those recommendations that they choose to approve, subject to legislative and federal approval. And the labor commissioner would have a seat on this board and assist with the investigatory phase of the board's process, as well as enforce all implemented recommendations. So that's the general overview of the bill, and now I will briefly run through an outline of the bill. So the home care workforce is defined as any caregiver providing publicly funded personal care, personal assistance, or temporary respite services who is employed by an agency to provide personal care services in the home, an intermediary service organization, or an agency contracted with the Aging and Disability Services Division to provide temporary respite services. In terms of convening the board, this is triggered after at least 50 home care workers file a petition with the HHS director, or if the director determines the board's convening is necessary. If a petition is filed, the director shall meet with representatives of the petitioners within 30 days of the petition's filing. Before the board's first meeting, which must be set by the director no later than 60 days after the meeting with the petitioners, the HHS director and the labor commissioner shall collect relevant data on the wages, working conditions, and compliance with relevant laws within the industry and share their findings with board members. In terms of the board's composition, the HHS director or their designee would chair the board. Board members would consist of the labor commissioner, 3 representatives of home care employers, 3 representatives of home care workers, and 3 representatives of home care consumers. Members serve on a voluntary basis, meaning they would not receive compensation, and they would be appointed by the HHS director after a public request for interested parties to apply. In terms of the topics that the board would investigate, in general, the board would investigate the minimum wage paid to home care workers and safe and healthy working conditions for home care workers. The bill does not prescribe the exact topics that must be investigated. Instead, it lays out a set of topics for the board to consider when determining what it will investigate. Those topics include reimbursement rates and wages, training, recruitment and retention levels, and worker protections such as race and gender-based discrimination experienced by workers. During its investigation, the board would have the authority to subpoena information and compel the production of paperwork relevant to the board's investigatory mission. In terms of the board's recommendations, a majority of board members constitutes a quorum, and any recommendations supported by a majority of a quorum would be included in the board's final report. And this report is due no later than 1 year after the board's first meeting and will be released online. In terms of implementation, the HHS director will decide which recommendations to effectuate via issuing regulations subject to legislative and federal approval where applicable. And the director may also disapprove of any board recommendations and may recommit the subjects to the same or a new board. Also, if the HHS director establishes the minimum wage for home care workers, the director is also authorized to adopt regulations concerning the payment of overtime. In terms of enforcement, the labor commissioner shall have the authority to enforce all recommendations that the HHS director has implemented, and the commissioner shall also enforce employee protections to prevent an employer from discharging or threatening to discharge an employee based on their participation in the board process. And violations would be considered a misdemeanor. Lastly, the board is charged with developing recommendations related to COVID-19 safety protocols, including the distribution of PPE, effective training, outbreak reporting, vaccine distribution equity, and the disbursement of federal relief funds. And these recommendations would be shared with the governor and the legislature. Lastly, I just want to walk through the proposed amendment. These are all minor changes to clean up drafting issues. So the amendment clarifies that the board is established by the HHS director, not the labor commissioner. It clarifies that the HHS director's meeting within 30 days of receiving the petition is with representatives of the petitioners, not all 50 signatories. It specifies that the HHS director shall convene the first board meeting within 60 days of the meeting with petitioners. It clarifies that the HHS director and the labor commissioner jointly conduct the initial investigation and present their findings. It clarifies that though there may be future iterations of the board that are convened, there is only ever one board at a time. And lastly, it specifies that the board's final report must be made publicly available online. So that's the walkthrough of the bill. And now we will hear from Farron Epstein, a home care worker from Las Vegas, who will share her experience as a care provider for the past 36 years.
Hello, Madam Chair and members of the committee. I'm really pleased to have this opportunity to tell you a little bit about my story. My name is Farron Epstein, and I'm going to speak about why I support SB 340 from the 3 areas every single day. I'm a single mom, the only caregiver to my 36-year-old son, who is an incomplete quadriplegic. I'm technically his personal care, but I'm advocate. My son's been disabled since birth. Through his 36 years, his disability has progressed to where he can no longer get into bed or out of bed by himself. He can't wash his own hands. He can't wash his own face. He can't brush his own teeth. He can't open a refrigerator. He can't pour himself a glass of water if he's choking. He can't call 911. In fact, he can't really do anything for himself. He depends on somebody to do almost all his daily chores and tasks. He's on a rigid catheterization schedule and a stellar bowel management program to keep him socially continent. I get up every 4 hours through the night to reposition him to prevent pressure sores because he can't even roll over by himself. Despite him requiring this 24/7 care, he gets only 26.75 hours of PCA care time and a few ISO hours a week. Our state has very limited Medicaid dollars and almost no waiver programs that meet the needs of disabilities. Many elderly and individuals with disabilities don't get the hours that they need to safely remain in their homes, forcing them and their families to either make incredible sacrifices or placing their loved ones in a long-term nursing facility. I will never do this. It will be over my dead body that my son goes into a nursing facility. But how is this in alignment with the commitment to provide home and community-based services when they get such minimal hours? I constantly feel like I'm living in a pressure cooker. The stressors just don't let up. I don't make a living wage. I can't afford to pay for my own health insurance. So I wind up, on the other hand, getting a subsidy from the Nevada Health Exchange. I worry so much about my own health because I don't believe that the current system can take care of my son. I've tried throughout the years to hire a personal care aide for him, at times to provide me a little respite, and at times to try to escape this catch-22 of living in poverty and going out and seeking a job that pays a living wage outside of the home. To find someone trained enough and willing enough to make $10 an hour for the responsibility and difficulty of this job is quite challenging. The high turnover rate of personal care aides, in my opinion, is that the pay is so minimal, as well as the conditions that the agencies ask of the PCAs, such as travel time, lack of training, no paid time off, no sick days, having to show up on your own time at the agencies to pick up your paycheck, limiting your hours, disrespecting you, total disrespecting you, and all of the unwritten and uncommunicated employee responsibilities that this job entails. Most eventually just find this job simply not worth it and quit. For me and many families like mine, the future feels hopeless that things aren't going to get better. We're trying so hard to keep our loved ones comfortable, healthy, and engaged within the family and the community. For us, there's no place to go to address any of these issues. We need to create this board to generate some accountability for the industry and agencies. Community-based services are the future, and we need to set our state up to be able to successfully deliver on those services. I ask that you support this bill for my son's sake and for families like mine who depend on this industry to deliver quality care. Thank you for allowing me to share my story with you today. I'm happy to answer any questions.
Thank you for your story. Senator Neal?
Senator Rowdy, that concludes everybody who was a part of the presentation. So we're ready for questions from the committee.
Hey, committee members, questions? I'll go ahead and start with one. Interested in the structure of the bill in that, if I'm understanding correctly, the state is one of the more significant payers of personal care assistance through our Medicaid and waiver programs. And so I think what's kind of interesting about the bill is that everything is put under the Director of Health and Human Services to do the investigation and to, I think, make recommendations on pay. But that same individual also has to be conscientious about the state's budget. And so it seems like that one individual, whoever's in that position, is going to be put into a position of needing to be the steward of the personal care assistants and their professional situation, and at the same time the steward of the budget that might be the cause for the personal care assistant situation not being great. And so I'm just interested in that tension, and if that's intentional, in that at least everybody who's engaged in decision making is at the same table, or if you see any challenges with that in terms of the structure.
So I think I'm gonna pass that one over to SEIU because I know what the struggle was to get this board composed. So I will let them answer that question.
Yeah, I'm happy to tackle that. This is Vanessa Torti. No, I think in recognizing that tension, I think the unique thing that we are trying to do here is to bring in voices that historically have not had a seat at the policy table, right? So the need to bring in the perspective of the employers, of the caregivers, of the consumers, who historically have not been able to have kind of equal footing in speaking to the structure of, particularly as you brought up the Medicaid programs. And I think it's particularly the people on the front line who are doing this work and are getting these services every day that know more about like the needs of what needs to be done to fix home care in Nevada than anybody else. And I think it's time for us to listen to them and make them a part of the solution. And we also kind of recognize that in terms of, the state's oversight of this industry, it really is kind of dispersed over several state agencies, right? You have the Medicaid agency, you have HCQC as the licensing entity over personal care agencies, and then you have the labor commissioner over general employment law. So, the need to bring in a multitude of voices and opinions in order to come up with the right solutions for this workforce.
Thank you for the answer. So I guess to build off of that, so do you see this more as a stakeholder engagement board, or do you see this more as a labor relations board?
I think it's set up to do both. I know one of their goals was to definitely have the labor relations piece because of the wage component that's in the board. It's just why they wanted the labor commissioner to be a part of it. The early discussions that we had was to try to make sure that if there was a wage issue, number one, not to take away any authority from the labor commissioner, but have the labor commissioner a part of the concept and the conversation. So that if an issue came up, at least you had a member on the board who would have jurisdiction over those issues. And I think the same concept was being considered for for Health and Human Services, trying to find the home that was best suited. Initially started off as a home under the Labor Commission, but then it seemed that it was better suited for it to be under HHS. And so it's kind of a blend. It's not, I wouldn't say that this bill gives a traditional board, but in trying to manifest all of the goals that SEIU wanted, it kind of became this blended, I would say blended task board. That's the best way I can probably try to phrase it.
I could just follow up on that, Senator. What tipped the scales to having it at DHHS for, I think put an extra H in there, DHHS, as opposed to under labor?
So what tipped the scale was kind of the things that they were asking to be done seemed to be better suited in terms of expertise for DHHS versus the Labor Commission. Labor Commission focuses on wages. They focus on enforcement of failure to pay wages. But in regards to the larger issues, so like in the back of the bill, trying to get into this issue of employment standards for home health, for home care, and the training and other things that they wanted to get into, and the systemic impact around home care employees, it seemed to be better suited for DHHS to get involved. And a lot of those provisions are in like section 16 and 17 of the bill.
Thank you. And just final question, have other states done something similar, and what have been the results?
Repeat that question.
Just wondering if there are other states who have done something similar and what have been the results.
That would be a great question for SEIU, because I think we might be, for this composition, I think we might be the first to attempt this variation. But I'll let SEIU speak to that, or Marlene Locker.
Yeah, so I can jump in and point out the states that have wage board enabling statutes already. So these are not specific to home care, but they have been used for other industries. And those are Arizona, California, Colorado, New Jersey, and New York. And I'm not able to speak to the details of the outcomes of all of those boards, but this is a concept that exists in other states.
But those are wage boards specifically, so more leaning towards the labor relations board concept than the stakeholder engagement concept?
I would say yes.
I would say yes.
Thank you. Other questions from the committee? Senator Kiefer.
Thank you. I appreciate that. To follow up on that, is it common practice that these wage boards create sort of differentiated minimum wages for different types of employees in each state?
Ms. Torty?
So that has happened under the wage boards. It's also, speaking more specifically to practice in the home care industry, it is a practice within Medicaid and other states to set specific wage and compensation standards for this industry. So it is common practice to set what percentage of the reimbursement, the Medicaid reimbursement rate, can be retained by the agency, or what percent of the rate has to be passed on to a home care worker in the form of compensation. Other states have set specifically a minimum wage for home care workers, and this has all been under CMS's guidance and approval.
Right. So the proposal before us would set a minimum wage outside of Medicaid reimbursement, right? So it would be inclusive of Medicaid reimbursement, but not exclusive to it, so that healthcare workers this would be a minimum wage across the board for this job classification, regardless of whether they're working for a Medicaid client or not.
No, this would be specific to only publicly funded home care.
Can you point to that in the bill? I missed that part.
So the way that the workforce is defined in Section 5, so a home care employee is someone who provides personal care services through a home care program. As an employee of a home care employer that is an agency to provide personal care services in the home. And then home care program is later defined in Section 8 to mean a program established by a state agency or local government, which provides in the home personal care services. And then it details specifically like the waiver programs or the Medicaid state plan programs as examples of publicly funded home care.
Why is this a better way to do it rather than saying agencies must pass on 85% of their reimbursement rate to employees?
I think that is up for the board to decide, like if that is the route of the recommendation around compensation for home care workers. I don't think that it specifically says a recommendation has to be around the minimum wage. It could be in the kind of form of a wage pass-through as you've described.
Thank you.
Other questions? Okay. We're going to go ahead and open the hearing for public testimony on SB 340. Again, we're going to limit it to 2 minutes. And again, because we do have 5 bills to hear today, I would encourage folks, if you're saying something that others have said before, you can say ditto or I agree with the prior callers. Let's all keep our testimony to 2 minutes or less if possible. So open it up for support of SB 340.
Thank you, Chair. Callers, if you'd like to testify in support of Senate Bill 340, please press star 9 now to enter the queue. Will the caller with the last 3 digits of 199 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Good afternoon, Chair and members of the committee. My name is Tess Opferman, that's spelled Opferman, speaking on behalf of the Nevada Women's Lobby. We are very appreciative of Senator Neal for bringing forward this bill, something that will help families, seniors, women, and people of color. Of the roughly 13,000 home care workers in Nevada, more than 3/4 are female and over 1/4 are women of color. These workers make a median wage of $11 an hour and a median income of $15,500 per year. This is far below the poverty level and is simply not sustainable. This leads to a high turnover rate in the home care industry, and caring, qualified workers are leaving the profession at a rapid pace. We have an entire workforce trained to care for our aging parents and grandparents, allowing our family members to stay in their houses and get the services they need, but we have to pay a living wage. These workers must have established training regulations and get fair pay and benefits. SB 340 is a key solution and will help protect these workers, ultimately meaning that those who are caring for our family members are well-trained, experienced, and invested in the jobs they have. We urge you to support this legislation that helps women, people of color, and families in Nevada, and we thank you for your time hearing this bill this afternoon.
Thank you.
Will the next caller with the last 3 digits of 338 state and spell your name for the record? You'll have 2 minutes and may begin now.
Good afternoon, Chair Ratty and members of the committee. This is Priscilla Maloney, Priscillamaloney, representing the AFSCME Local 4041 chapter of, retiree chapter. We are here in support of SB 340. We thank Senator Neal and SEIU for working together to bring this bill forward, and we would just echo or ditto the comments just made by the previous caller, Ms. Opperman, on the behalf of the Nevada Women's Lobby. Thank you.
Thank you.
Will the next caller with the last 3 digits of 600 please slowly state and spell your name for the record? You can try to unmute yourself by pressing *6, and you may begin now with 2 minutes.
Hello and greetings. My name is Irma Henderson, ErmaHenderson, and I'm a proud home care worker in Las Vegas, Nevada. I'm giving my support statement for Senate Bill 340. During the pandemic, I was faced with working without proper PPE for my clients, and I was afraid of being infected and bringing COVID-19 home to my husband. This bill would help make sure it doesn't happen again to home care workers when we face future viruses or another public health crisis. With SB 340, we can make sure all home care workers have the medical necessities to be safe. Now I'm talking to Nevada state senators who are now listening to us. We ask that you pass this bill. Make sure we and our clients have the protective equipment we need and help create good, or can I say great, or can I say magnificent paying jobs with benefits for the long overdue home care workers. Please respect us, protect us, and pay us. And thank you.
Thank you.
Will the next caller with the last 3 digits of 832 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Thank you, and good afternoon, Chair Ratty, Vice Chair Spearman, and committee. My name for the record is Terry Laird, spelled Terrilaird. I'm the Executive Director of the Retired Public Employees of Nevada, formed in 1976 with nearly 8,000 dues-paying members, many of who are retired. I don't need to tell you and the rest of the committee that as we age, we sometimes need to receive specialized care whether within the home where we are most comfortable or in a special care facility or hospital when necessary. But for the most part, when possible, care within our own homes is the preferable alternative, and highly qualified home care professional caregivers are essential to make that possible. The last year has also pointed out the dangerous conditions that sometimes present themselves in larger nursing home type facilities where viruses can run rampant. This makes in-home care much more preferable when possible. SB 340 seeks to create a home care workforce board needed to improve the working conditions for those that take care of seniors, disabled, and others unable to take care of themselves. RPEN supports issues that benefit our members, and as such, we wish to put our support behind SB 340 and urge this committee's support as well. Thank you.
Thank you.
Will the next caller with the last 3 digits of 278 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Good afternoon. My name is Dawn Vallencotter, DAWNRALENKOTTER. I live in Las Vegas, Nevada. I am providing a statement of support of SB 340. I live in Senate District 11 and am a constituent of Senator Dallas Harris. I've been a home care worker for 10 years. The low wage for home care workers in Nevada is $11.07 an hour. Most of us are struggling to get by on wages that are too low and too few hours to give our clients the care they really need. That's bad enough, but there are all these out-of-pocket costs. We need SB 340 to help fix this problem. I have to get my recertification training, and they do not offer it on Saturday. I paid $40 to get my recertification. I told my client and the office that I need a backup worker, and they said the board is full and we are trying to cover you. They ended up just signing me in for training because they didn't have anyone to cover me for my client. I didn't really get the training. And what happened to my $40? These kind of things happen a lot in home care workers. They wanted me to pay for fingerprints, and I said, it is the same fingerprints I had 5 years ago. I had to advocate for myself, tell them, you all should be responsible for the cost. Thankfully, they paid for me. Every home care worker cannot advocate for themselves the way I did to hold our employees accountable. That's why we need Senate Bill 340. Agencies need more oversight. We need a voice as caregivers, and we want a voice as frontline workers. Thank you for listening. Respect us, protect us, and pay us.
Thank you.
Will the next caller with the last 3 digits of 724 please slowly state and spell your name for the record? You can try to unmute yourself by pressing *6, and you may have 2 minutes.
Good afternoon. My name is Carol Matrone, CarolMatrone. I reside in Las Vegas, as well as my daughter Maria, who turned 30 yesterday. I am here supporting SB 340 for myself and on her behalf. My daughter is significantly challenged and needs maximum care for all her activities of daily living. She first received personal care services in 2000 after major orthopedic surgery. She resides in an intensive supported living arrangement supported by Desert Regional Center and has 24/7 awake care from PCAs and direct support professionals through a subcontractor of DRC. I have been her unpaid caregiver for the last 30 years. I retired November 2020 from state service and dreamed what retirement could be. In a few brief weeks in November, both of us had 4 COVID-19 tests, almost back to back, and COVID near misses from personal care attendants who traveled to numerous clients throughout their workday. When this occurred, the agencies would pull all providers from our home, and I was the last care provider standing. I decided to become a paid caregiver at this point. I currently cover 4 shifts as needed shifts when there is no available PCAs. I'm doing this physically taxing job at age 63, and my retirement is not currently a reality. I'm not necessarily here for my. I am here to speak on behalf of, and I'm going to say it, the hundreds of PCAs who have filtered through my daughter's life since 2000. These providers often travel to 3 to 4 clients a day, all over the city, often working 10 to 14 hours a day to make a living that can support them and their families, and they barely make ends meet. Low pay, long hours, no travel stipends, inadequate training, and no sick or paid time off plague these workers. Trust me, they do not do this for the money. They do it for our vulnerable Nevadans because they do it from their heart and soul. When a PCA seeks to improve the quality of their life and leaves services for my daughter, it devastates her. Her care involves some of the most personal care and bladder strategies. And she begins all over again with a stranger. Retention and recruitment of this adequate workforce is paramount for our vulnerable citizens, as some receive the most complex care. I speak today in strong support of SB 340 to bring stakeholders to the table, to begin a conversation to improve the quality of life for these 13,000 plus workers, and ultimately improve the quality of life for our most vulnerable population. I will say this in closing, that trust me, you may in the future need a caregiver, be a caregiver, or hire a caregiver, and your loved one or yourself deserve one who is respected, protected, and earning a decent living wage.
Good, right. 63, baby.
Yes, I'm not sure if we're having a problem with that call.
Chair Ratty, this is BPS here. It looks like the caller cut out. So I did mute her because it looked like she was having connection issues. We can circle back later if you'd like.
I think we got the gist of her comments there, so thank you. Let's keep going.
Certainly, Chair. Will the next caller with the last 3 digits of 951 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Good evening. My name is Tyree Love. That's Tyreelove. I live in Las Vegas, Nevada. I am providing a statement of support for the SB 340. I have been a caregiver for 12 years. I'm proud of what I do. I want to provide a highest quality of care to my clients so that they can stay safely in their homes instead of going to a nursing home. That's what they deserve. But it's hard to make a living doing this work, even though helping senior citizens and people with disabilities has never been more important during this pandemic. Most of my clients can't get enough hours given by the state to get the level of care that they deserve. It's frustrating for me because I can't deliver the quality care that I know that they deserve. I have to drive all over the city to provide a couple of hours of care for one client and rush back to another client and another client. SB 340 will help us improve the quality care of all home care clients and improve the quality of life and 13,000 home care workers like me in the state of Nevada. SB 340 will give workers, employees, and clients a seat at the table so we can talk about the amount of service clients really need. It would be great if the clients can have more hours. It would be guaranteed less driving and more time to provide quality care for my clients. Thank you to the committee for hearing me today. Please pass the SB 340. Thank you for your time.
Thank you for your time. So, and in speaking of time, if you're still on the line to testify in support of this bill, if to make sure that we can get to as many folks as possible, if you could limit your testimony. If somebody has said what you're planning on saying, you can just say, I agree with those who've gone before me. And anything you can do to help be brief will help us move the meeting along.
Thank you, Chair. Will the next caller with the last three digits of 567 please slowly state and spell your name for the record? You may begin now.
Good afternoon. My name is Tracy Richards, TraceYRichards. I live in Las Vegas. I am providing a statement of support for SB 340. I have been in the caregiving field for over 15 years. As a home care worker, I am responsible for everything our clients can't do for themselves. Yes. Many of our clients no longer have family or friends to help them, so they depend on us for everyday tasks. That includes bathing, feeding, using the bathroom, buying their groceries, and cleaning around the house. My clients are giving a very limited amount of hours of care every week. But what is worrisome is that some of my clients don't always get the care hours they deserve. From my experience, unfortunately, it's the Black clients who are not getting those hours. We know for a fact Black people face inequalities in the healthcare system in this country. And we know COVID-19 has affected the Black community more than other communities. So we cannot allow that to continue and repeat these injustices in the home care industry. Home care workers like me and my clients, like the people I care for, need our voices heard and seats at the table. The other challenge I would like to raise is that it's truly a hardship for us caregivers to have to pay for our fingerprints, TB shots, certification training, CPR first aid, just to start a job. I recently moved to a new agency. I did not have the $65 for the fingerprints that I just previously paid for the previous agency, so I could start with my new client. This impacted me. It kept me from caring for my client. That's why we need to pass SB 340. We'll be able to work with home care personal care agencies and the state to develop solutions to the serious inequalities too many of us face on this job as workers and our clients face in their homes. Thank you for your time. I hope you support this important bill.
Thank you.
Will the next caller with the last three digits of 729 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now. If you're having trouble unmuting yourself, you can press *6.
Hello.
Hello, caller. Please proceed.
Hello, my name is Rosita Love. Good afternoon. ROZETTA LOVE. I live in Las Vegas, and I'm providing a statement of support for SB 340. I live in Senate District 4, and I am a constituent of Senator Dina Neal. I have been a home care worker for 11 years, and I'm also a native of Las Vegas. I have seen our city grow, and the need for home care service keeps growing as well. I'm here today to ask you to pass SB 340 and create the home care standard board. We need to investigate the issues facing home care workers like me and also our patients. We do this work because we care deeply about our clients and our community. We don't expect to get rich doing it, but we do deserve to be treated fairly, and our clients deserve the highest quality care. Right now, about half of home care workers leave their job within a year. It's essential work, but too many people can't make a living doing it. My hope is that we reform the home care system and make home care jobs good quality jobs with livable wages so that the next generation, I'm going to say that again, the next generation of home care workers can proudly, let me say that again too, proudly take care of our loved ones in need of care. Thank you for listening. Thank you for supporting all those that are supporting SB 340.
Thank you.
All right, will the next caller with the last three digits of 333, please slowly state and spell your name for the record. You'll have 2 minutes and may begin now. It looks like you are still muted, so you can try to unmute yourself by pressing *6. Once again, caller with the last three digits of 333. Please slowly state and spell your name for the record. You can try to unmute yourself by pressing *6. All right, we will circle back to you, caller. Will the next caller, whose last digits are 242, please slowly state and spell your name for the record. You'll have 2 minutes and may begin.
My name is Cheryl Knight, CHERYLKNIGHT. I live in Carson City, Nevada, and I'm providing a statement of support for SB 340. I live in Senate District 16, and am a constituent of Ben Keycapper. Our system for caregivers and the clients who need them is broken. This bill, SB 340, will provide those of us who are actually involved in the caregiving field a seat at the table to decide how to best manage the funds that are provided to the state of Nevada for both clients and caregivers. It seems currently that the state would rather pay for a hospital stay or put a client in a nursing home to care for them, instead of paying a decent wage to a caregiver to take care of that person in their home. Many clients need more hours to be taken care of properly. Clients and caregivers both need PPE provided to protect them. As a caregiver, I can tell you that every client is different, and broad sweeping rules about who gets what just don't work. Individual client needs should be able to be considered. As frontline workers, caregivers need PPE, training, and education that is not at their own expense. We get people who burn out too quickly because the pay is too low. Half of the workforce leaves the job within a year. And when we pay so little, when we don't provide proper training, equipment, sick days, we prove as a state that we don't truly value this work and respect these workers. People who are caring for others' personal needs deserve to be paid better. Nevada needs people who are actually involved in this work to be a part of the process in making the decisions on how to spend the allocated funds for our state. Without that, we have poorly run offices, underpaid workers, clients with not enough care and consideration. The list is very long. We need to fix the broken system, give the clients the hours they need for proper care, and pay the workers a decent wage. Please support SB 340 so we can work to create a system that actually cares for people. Thank you.
Thank you.
Callers, if you've recently joined us, we are on testimony in support of Senate Bill 340. If you'd like to give testimony, please press *9 now to enter the queue. Will the caller with the last three digits of 333 please slowly state and spell your name for the record. If you're still having trouble being muted, you can try to unmute yourself by pressing *6, and you may begin now with 2 minutes. All right, Chair, at this time it appears no other callers wish to give testimony in support of SB 340.
Thank you, BPS. Let's go ahead and go to testimony in opposition to Senate Bill 340, also at 2 minutes.
Certainly, Chair. Callers, if you'd like to give testimony in opposition of Senate Bill 340, Please press star 9 now to enter the queue. Will the caller with the last 3 digits of 687 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
Good afternoon. My name is Irma Nunez. That's IRMA, NUNEC. Live in Las Vegas, Nevada for 16 years. I want to provide a statement of support for Senate Bill 340. Being a home care worker for 12 years, I work at 3 agencies. I care for 7 patients, and I'm supporting Senate Bill 340 because as a caregiver, I deserve health care for myself. I have personal health care issues. I am a diabetic person and need to be under doctor's care, which is very costly. Around 5 months ago, I had a medical issue, which it was a hemorrhage. Went to the UMC emergency care. My bill was pretty costly. I provide care for others, but my job doesn't give me the benefit to take care of myself. This is why Senate Bill 340 is very important for me and other caregivers in the state. As frontline care workers, we are waking up every day, working all day and all night long to ensure the health of our clients, but we like our health being cared for too. Our work is essential, and during COVID, we risked our lives to do our job. I am asking, please, today for you all to support and care about health and well-being by supporting this bill, Senate Bill 340. It will create the board that will investigate whether care providers have access to qualified and affordable health care. I want to thank the committee for hearing my story today. Please support Senate Bill 340. I thank you for your time.
Thank you. Secretaries, let's note for the record that that was actually testimony and support. If you are on the line, we are now moving to folks who do not want to see this bill pass. So we're going to move to opposition. So please only raise your hand if you would like to testify no on this bill, that you would like to not be in support, or you would like to be in opposition to Senate Bill 340.
Thank you, Chair. Callers, once again, we are on opposition. If you would like to give opposition testimony to Senate Bill 340, please press star 9 now to enter the queue. Will the caller with the last 3 digits of 400, please slowly state and spell your name for the record. You'll have 2 minutes and may begin now. You can try to press star 6 to unmute yourself.
Good afternoon. My name is Sean Slatter, SHAWN SLATTER. I thank the committee for the opportunity to voice opposition to this bill. I speak very candidly. I don't have a prepared statement that was clearly prepared by outside parties, but I speak at great risk of my business. I own and operate Right at Home Las Vegas, one of the larger PCA agencies in Las Vegas. I've been the provider of choice and employer of choice for the last 5 consecutive years. I oppose, and I also come to you as an elected member of the PCAN Association, which you've received 2 different letters from in opposition. Should the committee not be aware, our industry is already regulated by the Department of Health and Human Services under Regulation NRS 449 that depicts and calls regulation into what we are supposed to be training and not training for. Many of the speakers for this bill have spoken, speaking of various trainings and things that they have paid for. In Nevada, it is illegal for any agency to require anybody to provide training or to pay for their own training. Every agency is required to provide said training. This is already under the books under 449. For the fingerprints, the health backgrounds, physician statement, 2-part tuberculosis, these are state mandated by the legislators yourselves that these employees must have in order to perform work in this industry. We simply do not have the budgets to pay for these said things. we're all in favor for increasing wages, but that oftentimes is depicted by what Medicaid reimbursement rates are. Those, again, are set by you, the legislators. We understand there are bad apples out there, and we've been working as an association with the Department of Health and Human Services, as well as the Labor Board, to get those agencies to act accordingly and follow those labor laws. I've recently sat down with Senator Nicole Conzaranzi and shared some of these things, and she was supposed to get back to me, never did. But as an owner and operator of the leading provider of choice and employer of choice for 5 consecutive years, we do everything we can to take care of our PCAs, and it goes step 4 for my employees that work for me. I will share that one of the employees that marked that she was actually for this bill abandoned their caregivers. They no call, no show, and that's the greatest thing that harms our citizens, our seniors that we serve. So as an owner, we ask the committee to oppose this bill, as we already are regulated under 449. Thank you for your time.
Thank you.
Will the next caller with the last 3 digits of 717 please state and spell your name for the record? You'll have 2 minutes and may begin.
Good afternoon, everyone. I'm Connie McMullen, CONNIE, capital MCMULLEN. I am the lobbyist for the Personal Care Association of Nevada. And I submitted written testimony. At the end of my testimony, I gave an example of a gentleman who passed away because he did not have a caregiver. That was his choice, I suppose. Maybe he couldn't afford it. That happened in 98, 99, when I was walking with Seniors Corner and on the Knock and Talk with Reno PD. I was witness to that because I wanted to, and I wanted to learn what was out there. When I was asked to help regulate and get all this industry licensed in 2002, I immediately got out there and testified in front of the legislature. I have been participating in testimony every year since then to help form a better personal care industry in our state that had credentials and that was regulated in the same manner, and it all applied for every agency. When the Personal Care Association was formed, I was so impressed that happened. And when I was asked to work for them, I was also thrilled to do that. I have to believe that every one of our members, and we have at least 26 to 30 agencies working for us, works very hard to meet high standards of their company. We have a standing item on our agenda of unlicensed agencies. We've been going after the care.coms and those people that try to put caregivers on Craigslist to put in the home for probably 6 years now. And for those 6 years, we have tried to get fees. I asked the governor this year. I was told no. Outgoing Chief of Staff Mike Wilden asked Director Whitley to please do that. He told him no, and it's been going on and on. We had Assemblywoman Titus write a letter to Governor Sandoval, to no avail. The drive requirement fees, that's a federal requirement. The PPE, that was the governor's decision not to include personal care on the first line of defense. The rates, as I said, that's the director's decision. Training, it's in public and
Ms.
behavioral
McMullen,
health.
you are at your 2 minutes, so if you could wrap up your comments.
I think I made my point. Thank you. And I appreciate all you do for our state. Thank you.
Thank you very much.
If there are any more callers who wish to testify against Senate Bill 340, please press *9 now to enter the queue. Chair, at this time, no other callers have indicated that they wish to testify in opposition to Senate Bill 340.
Okay, thank you. Let's go ahead and see if there's any testimony in neutral. I first wanted to check within the Zoom, is there somebody from DHHS who needs to testify neutral?
Good afternoon, Chair Ratty, if I may. This is Beth Handler.
Please go ahead.
Thank you. Good evening, Chair and members of the committee. Beth Handler, Deputy Director of Programs, Department of Health and Human Services. Thank you, Senator Neal, and thank you to all of Nevada's home care workers. The Department of Health and Human Services acknowledges the intent of SB 340 to assure equity, living wage, and advanced rights for home care providers. The COVID-19 pandemic magnified the need for home care employment standards and addressing inequities. It's already been mentioned that 5 states have existing statutes under their labor code enabling the creation of workforce boards, also referred to as wage boards. Portions of the authority of labor standards and wage standards in this bill would be new to DHHS authority, and a fiscal note will be required to create this type of infrastructure. That total amount is pending, but we will have to submit a fiscal note for this bill, and we will be in touch with Senator Neal. Thank you.
Thank you. BPS, if you would go ahead and open up callers for neutral testimony on SB 340.
Certainly, Chair. Callers, if you'd like to testify in a neutral position for Senate Bill 340, please press star 9 now to enter the queue. Once again, that is for a neutral testimony. Please press star 9 now. Chair Ratty, at this time, no callers have indicated that they wish to testify in a neutral position for the bill.
Great, thank you. So we'll go ahead and close the testimony on SB 340 and take it back to the sponsor, Senator Neal. Any closing comments?
Yes, thank you, Senator Ratty, and thank you for the committee for listening to this bill. It's been a long day, and we'll be back for a second one. But I just wanted to make this statement that this bill is not set out to say that there are bad actors. It's about creating an industry standard so that there is a place and a voice for the issues to be heard. Right now, there is no voice, there is no place. And so outside of their employer. And so that is what this bill creates. I myself hired a company. It was owned by a single woman, and she was a good actor, and my family paid the top part of the wage at $22 an hour in order to have a caregiver. So I would like the support of this committee for this bill, but it is within your wisdom. Thank you for the hearing.
Thank you. All right, for the rest of the agenda, we are going to go in order. So the next bill we will hear is SB 309. Checking with you, Senator Neal, do you have your presenters for SB 309?
Yep, they look like they're on.
All right, so close the hearing on SB 340 and open the hearing on SB 309.
Okay, thank you, Senator Ratty. So I am here to introduce SB 309. There will be 2 co-presenters, Joanna Jacob from Clark County and Mr. Schiller, and I believe Cody Finney for technical questions. SB 309 has a very unique origin. Last session, in 2019, AB 73 came out. It was a bill that came in from the city of Las Vegas, and I, as chair of taxation on the other side, tampered with the bill and basically mandated that the local governments come together and find solutions for homelessness. And apparently they did. And so now we have SB 309. So I will turn it over to Joanna Jacobs.
Thank you, Senator Neal, and thank you, Chair Ratty, members of the committee. Joanna Jacob, Government Affairs Manager for Clark County. Thanks for that introduction, Senator Neal. We found through our effort under AB 73 some recommendations for solutions, as Senator Neal stated, this is the genesis of SB 309. Just by way of background, really quickly, because I know you have a lot left to do. AB 73 working group met approximately 12 times during last year. We came up with recommendations to address homelessness, but we also identified our needs and our funding gaps and solutions that we can use as a roadmap and policy map going forward. Understanding the challenges of the pandemic that has posed both the state budget and local government budgets, some of those things will have to wait. Obviously, funding is a critical component and of a need that we found in Southern Nevada. I will just highlight really quickly, just to let you know, we identified our system capacity to address homelessness as part of that effort. In 2019, our local governments do a lot. We have worked on a regional basis to address homelessness. We have, between the local governments participating in that group, have collectively spent $55 million committed community-wide to address homelessness across our service continuum. But one of the things that we identified as the single largest barrier to the expansion of affordable housing services and housing and services really in our region was funding, maybe not a surprise to these committee members. We have a funding gap, and I will file this report, I guess, if anybody would like to read it. I will file it with this committee afterwards, but we did identify a funding gap in housing alone in 1 year of $46 to $55 million that we would need to address our homeless population if we were to house our homeless population. Because of the pandemic, I also want to note, this is also perhaps not a surprise to this committee and the members who sit on this committee, that we are seeing an increase in newly homeless individuals and families. So just briefly, this AB 73 working group took strategies to address homelessness. We broke it out into 6 areas. That included regional oversight. The regional framework that Senator Neal put forward in AB 73 works well. One government working alone cannot address this on their own. We know that we have significant needs in housing. We know we have significant needs in behavioral health services and intensive case management, coordination of data, prevention and intervention, and affordable housing development incentives. Those 6 categories are in our report. The SB 309 committee builds off of one of those, which is the regional oversight idea. The committee specifically in that, and this was a joint recommendation from all of the people who sat on the committee. So we had representatives from nonprofits, we had participation from the state, we had the municipalities, Boulder City, City of Henderson, City of North Las Vegas, City of Las Vegas, Clark County, of course. And these were joint recommendations. Specifically, we felt that we needed to take advantage to leverage public-private partnerships to help us at the local government level and the state government level to finding solutions. So we have some examples of where this has worked so far and is underway in Southern Nevada. So, and this is really an example that goes to what we're proposing in SB 309. We have managed care vendors who actually serve the people who mostly are at risk for housing and need housing supports. And they often do partner with local government to help with funding housing projects and those things. For example, in Arizona, as part of a community reinvestment initiative that you see proposed in this committee, one MCO partnered with a local nonprofit to provide funding for a 500-unit supportive housing unit. And how those things work is that they partner with the local government to help build that, and then usually they mix and braid funding together, and the managed care company will provide case management, and it provides housing supports for the people who are enrolled in their programs. We have a program like that in Southern Nevada, started with a partnership between Clark County and Health Plan of Nevada, and it's been since extended to all 3 MCOs, where it's called Hospital to Home. It's a rapid rehousing program for medically fragile and literally homeless households. We use our HUD funding at the county level, and we partner with the MCOs to provide case management for their members. And that is in partnership with a nonprofit as well, Help of Southern Nevada. It's been very successful. To date, we've served 139 members through this program. And so we looked at some of those things that are working, and we're looking at a way to continue this collaboration. The state too has been researching ways to address how to maximize Medicaid solutions to reduce the rate of the uninsured and tackle some of the social determinants of health that act as barriers to accessing healthcare. And then finding ways to maximize community reinvestment dollars was a recommendation made to the state in a report that was done by Princeton University, published in 2000. So SB 309 and the committee proposed will allow a forum for collaboration between the state, the county, local governments, nonprofits, and the managed care vendors selected in the forthcoming RFP to identify opportunities and, more importantly, gaps that we have in our existing service delivery continuum. I will walk briefly through the bill. I can then defer it back to Senator Neal for questions. We do have Kevin Schiller on the line for technical assistance, and also Cody Finney, as Senator Neal noted. So just briefly, it's a fairly short bill, Senator Ratty.
Ms. Jacob, I think we're probably good. It is a fairly short bill, and so
yeah, okay.
We'll just let folks ask questions if they have them.
Sure, we'll go to questions. Thank you.
Committee members, do you have questions? Senator Kieckhofer.
Thank you, Madam Chair. Appreciate it. So, and maybe this is a question for Ms. Finney. Ms. Jacobs referenced the forthcoming RFP for managed care. I guess there's going to be a requirement that our MCOs make some sort of investment level back into the community. Can you talk about that?
Thank you, Senator Kieckhofer. Cody Finney for the record, through Chair Ratty, to you. Yes.
Please go direct.
Thank you very much, Senator. I can speak to that requirement. Our managed care RFP was published on March 17th, and it does include a requirement in the scope of work that would have any vendors that participate in our next contract starting in January of 2022 participate in this community reinvestment fund as a portion of their pre-tax profits, and that would then be distributed by a plan that the vendors would develop and the state would approve.
What portion of their pre-tax profits?
The current scope of work is 3% of their pre-tax profits.
Nevada-based, right? I assume.
Yes, for this program.
Is there anyone else? Are there other industries we do this for? Do this with? I mean, new concept. And I guess why MCOs? They're not the root cause of homelessness, from what I can tell. And we have contracts with a lot of other types of vendors, hospitals, physicians. Why MCOs?
Senator Kieckhofer, thank you. Cody Finney for the record. This is a program that has been implemented in some other states, and the mechanism is allowable under the managed care guidelines from CMS. Other types of vendors that you mentioned would not fall into those managed care guidelines, and so we wouldn't be able to work with them. That's the Medicaid aspect of this. I certainly defer to Ms. Jacobs if she has additional information.
I think just on the finance piece, so it doesn't, so actuarially set PMPMs are done absent this calculation, right? So this doesn't increase how much we pay on a per member per month level for states. We just rake it sort of out of them on the backside.
Senator Kieckhofer, Cody Finney for the record. So your question is, does this impact the capitation rates?
Right.
It's my understanding that it could. We're currently in the process of setting the capitation rates for 2022. I can certainly confirm that with the other states that have implemented such a plan.
Okay. All right. Thank you, Madam Chair. Thank you, Ms. Finney.
Thank you, Senator Kiefer. Additional questions? I have a question, and it's primarily why just Clark County? If we're doing a statewide bid on MCOs, why wouldn't the same structure apply to Washoe County and perhaps rurals?
So I can take a quick stab at that one. Dana Neal, for the record, it's my understanding that Washoe did not want to be a part. So it wasn't a direct exclusion. I know that the bill had focused on the South, that included Mesquite and Boulder City, but because that initially AB 73 was brought by the South, but it's my understanding there was a conversation that Washoe doesn't have an interest in being a part of this structure.
And Chair Ratty, if I may, I'd just like to also note that I think it was because the recommendation and the genesis for this committee really came out of conversations amongst the regions in the South. And that's really the recommendation and the genesis for this bill, is because we felt that we're facing such a tremendous need in Southern Nevada. I don't want to belabor the point, but in this report, we have a significant gap and a way to go that we felt like we needed to have more people at the table to help us address this gap. The bill is written permissively. I will also note, just so you see that there's an amendment, I neglected to say that in my presentation, that we worked on with Senator Neal, that gives Director Whitley some more discretion to appoint non-voting members that could build upon the committee.
Chair Ratty, I'm so sorry to interrupt. If I just might have one indulgence.
Yes, of course.
Our RFP will be for Washoe County and Clark County. It's possible that could expand, but currently doesn't address the rurals. It's just that this is so high profile. I wanted to make sure that was clear here. Thank you very much.
Thank you.
Well, great. And so I guess the answer I heard was that, so first of all, I'm going to need somebody to follow up with me from Washoe County to understand why we wouldn't want funding for services. And maybe the amount of funding that would be generated in a county of that size wouldn't cover the cost of implementation. I mean, maybe there's a reasonable explanation, but I'm going to need somebody to follow up with me on that. I guess then the second piece is I heard the answer being permissive. So do you think the bill as written would allow for a similar structure to be set up in Washoe County?
Senator Ratty, this is Joanna. I was looking at the language of the bill, and I was thinking that it could be easily modified if we needed to modify it. So maybe permissive wasn't the correct term. I apologize if I misstated. I was just looking at the terms of the bill and thinking that there is some room there. And certainly following up on your point on Washoe County, I do not represent Washoe County and cannot speak for them, but I will have someone follow up with you directly.
I appreciate your efforts, and maybe now is just a minute to acknowledge that Joanna's done a lot of work on a lot of other bills to make sure that not just the county she represents, but everybody's at the table. So thank you for that, Ms. Jacob. Mr. Schiller, are you trying to get in?
I was just going to make one comment, Chair and members of the committee. Ditto to what Joanna said. I really, and to Chair Ratty, I think you heard we had a meeting yesterday where we were speaking to kind of the implications of addiction, behavioral health, medical access, all those pieces that are so significant in terms of making the dollar go farther. I want to just kind of echo that this really, it's kind of an alignment issue. The days of kind of county funding, social service, and kind of medical access, when you look at Affordable Care Act, if you look at all the things that have changed, you start looking at diverse communities, barriers for medical front doors, much like we talked about with opioids yesterday. these partnerships exist and they've continued to evolve. I will say I'm a big champion of this because I work with those MCOs in a current structure. But just like anything else, there's contracts, there's dollars, there's those pieces. It's not so much to control it as much as it's to make sure we're aligning our service array with their service array to create increased access and efficiency of funding. So it really is about making the dollar go farther where we have the opportunity. And just to echo the hospital to home program that was just spoken to give you some example of that, the win in the MCO world is if that client's in the hospital, they're paying 10 times what they would pay in a provision of services that we're providing in a program. So that reinvestment side is just making sure when they reinvest, how we can align with their benefit in terms of what works and in terms of what works for us. And so I just really want to echo that, especially we're kind of in a really opportunistic time in a crisis where we have a lot of one-shot funding coming and a lot of pieces that are going to fund things. But at the ground level, what we have to be able to do is create that front door and access point with our large partners. And obviously, you've already heard one, the state is our largest partner, and we've mastered that in terms of that piece. But now it's kind of like the third leg because now that's coming in. It's really become a part of our practice. We don't really get to talk about it a lot, but I think it's really the wave of the future in terms of how we increase service levels. And it's really a win-win. It's not necessarily a win-lose because on the MCO side, they have contracts and they're accountable to those contracts, which is great. And then our clients are their clients. And I think that's the other piece in terms of where are those gaps? How can the county come in and fund a gap? Where do I take my dollars where I have money to fund a gap that isn't necessarily covered in an MCO plan, but it actually creates a service array for that hard to reach addicted client that may be in West Las Vegas as an example, or maybe tied into some rural area. So I just throw that out there as an example to say, that there's a lot of collaboration that's happening. And this is a great way of highlighting so that our kind of our social determinants of health are aligned when we get down to the practice level. So I think there's a lot of wins in this. And I'll be honest with you, I feel very passionate and excited about this because I think it's going to highlight things that I think everybody can build on.
Thank you, Mr. Schiller. And the passion comes through. And I think there's a lot of alignment on this actually with a significant growth and understanding of social determinants of health and understanding how the state, local, and the payers have to be aligned on figuring out how to be a lot farther upstream in terms of interventions. And that's why I'm puzzled on the Washoe County piece, because I know that we've been working specifically on the Build for Zero process. I know that the MCOs, at least the major one, have been at the table as part of that conversation in Washoe County. And so again, just somebody could get me an answer to that. Don't have to make folks do it, but I just want to make sure if they get to a place where they want to do it, that the opportunity is there. So appreciate all of that. Committee members, any other additional questions? Senator Kieckhofer.
Thank you, Madam Chair. Appreciate the second round. I'm still taking a step back. I apologize. So I assume that there are specific services that the MCOs provide that qualify towards meeting this certain threshold. And they have to, it looks like they provide that report. But ultimately it looks like it's just a report, right? They get to dictate how it's, or how they spend their money, I guess. Unless the effort is to try to direct how they spend their money, which would beg the question of why they're then not even on the advisory committee. So is there a requirement now, I guess, under our MCO contract for community reinvestment?
Cody Finney, for the record, there is not.
Okay. Are there in the contract, does it lay out the specific categories that qualify towards meeting that threshold outside of, I mean, I know it can't be payments for services provided.
Cody Finney, for the record, there are two particular items in the current RFP that are specific. As examples, the remainder of this section requires that the vendors provide a plan and that the state approve the plan. So in my imagination, if they come back with a plan that does not adequately meet the advice of this body, then we would be asking for a redrafted plan, providing feedback on that. That's a process we go through with the managed care organizations on a fairly regular basis.
Okay. What's the estimated dollar figure that you expect to be sort of contributed through the community reinvestment piece of the contract?
Cody Finney, for the record, I'm embarrassed to say I don't have that in front of me, but I will be happy to get it for the committee.
Thank you. Thank you, Madam Chair. Thank you,
Chair Roddy, can I just follow up really quickly to Senator Keffer? I will tell you that the intent is not to dictate, to make an MCO sit on an opportunity or to dictate. That's why we wrote it as recommendations, and we wrote it two ways. Also, if you look in the bill, that the local governments will also be reporting to the MCOs because they have this plan requirement to deliver to the state. We often, I will speak this from the county, don't do a good job saying what our initiatives are, right? So we contemplate this as a collaborative committee where we can share our initiatives and see where we can layer in and help meet one another's objectives, if that makes sense, because this is really something that is supposed to be also the reporting that's going to be required, I think, is very important for transparency for both the counties and for the MCOs and for this committee, because you'll see where we might be able to do these partnerships and to know what is happening in these collaborations between the state, local government, and managed care. And so this is why in the amendment we have the reporting going both to the director of HHS and to the legislature, and you'll get an annual report. So thank you.
Okay, additional questions? All right, let's go ahead and open up the lines for support of SB 309. Again, this is testimony in support of SB 309, and if you could keep your comments to 2 minutes or less.
Thank you, Chair. Callers, if you'd like to testify in support of SB 309, please press star 9 now to enter the queue. Will the caller with the last 3 digits of 087 please slowly state and spell your name for the record? You'll have 2 minutes and may begin now.
For the record, my name is Jared Luke, Jaredluke, the Government Affairs Director for the City of North Las Vegas, calling in support of Senate Bill 309. Thank you, Chair Ratty, Vice Chair Spearman, and members of the committee. I know this has been a long day, so I will make my comments short and submit something in writing. But we appreciate the invitation to collaborate and provide input with this group. We're looking forward to developing creative measures to help those that are in need. And I want to thank Senator Neal for bringing this forward. This is an important bill. Thank you, Chair.
Will the next caller with the last 3 digits of 380 please slowly state and spell your name for the record? You'll have 2 minutes and may begin.
Thank you, Madam Chair, members of the committee. For the record, Kelly Crompton, KELLY CROMPTON, representing the City of Las Vegas. I'd like to echo the remarks from our municipal colleagues, the county, and thank the bill sponsor for this bill. Thank you.
Will the next caller, the last 3 digits of 948, please slowly state and spell your name for the record? You'll have 2 minutes and may begin.
Thank you, Chair Ratty and members of the committee. For the record, David Cherry, spelled DAVIDCHERRY with the City of Henderson. My title is Government Affairs Manager. The City of Henderson was an active participant in the AB 73 working group that met during the interim following the 2019 legislative session, which sought to create a regional focus on enhanced around the issue of homelessness. And the committee envisioned under SB 309 would present another opportunity to continue this focus and to address other issues related to reinvesting funds in our community. So we appreciate the sponsor bringing this bill forward and the committee having this hearing today. And I also appreciate the time sharing my thoughts with you. Thank you.
Thank you, caller. If there are any other callers wishing to testify in support of Senate Bill 309, please press *9 now to enter the queue. Chair, at this time, no other callers are wishing to testify in support of SB 309. I apologize for the delay there, Chair. It looks like there are no other callers who wish to testify in support of SB 309.
Okay. Anybody on the Zoom call from DHHS that needs to testify in neutral on this bill? Right, I'm not seeing any. So BPS, if you would open up the line for testimony in neutral of SB 309.
Certainly, Chair. To clarify, you said neutral, right?
Yes, but I skipped. I suppose we should also take testimony in opposition. My apologies. It has been a long day. Not intentional if you're out there in opposition. So please, if you'd like to testify in opposition to SB 309, go ahead.
Thank you, Chair. Callers, if you'd like to testify in opposition to SB 309, please press *9 now to enter the queue. Once again, that is *9 to testify in opposition to SB 309. Once again, to testify in opposition to SB 309, please press *9 now to enter the queue. Chair, at this time, no callers are wanting to testify in opposition to SB 309.
Let's go to testimony in neutral. Thank you.
Certainly, Chair. Callers, if you'd like to testify in a neutral position for Senate Bill 309, please press *9 now to enter the queue. Once again, that is *9 now to testify in a neutral position for SB 309. Chair, at this time, no callers have indicated that they wish to testify in a neutral position for SB 309.
Okay, thank you. I'll take it back to the sponsor for brief closing comments.
I will be real brief, Senator Ratty, Chair Ratty. Thank you for hearing this bill. Thank you for the marathon day. Thanks to Clark County and Ms. Finney and Mr. Schiller for being present to co-present on this. You're awesome. Thank you, committee.
Thank you. All right, we're going to go ahead and close the bill or the hearing on SB 309 and check in with Senator Hammond. Senator Hammond, do you have the presenters that you need for SB 305? Senator Hammond, are you there?
I am here, sorry.
That's okay. I just wanted to check in with you and make sure you have the presenting team that you need for us to start on SB 305.
I believe we are still all here, yes. Let me make sure I see her in here somewhere. Yes, we're all here.
All right, so we are going to go ahead and open up the hearing on Senate Bill 305 and invite Senator Hammond to the virtual dais.
Thank you, Chair. And if I just get myself straight, I had all this stuff all organized a minute ago, and then somebody came and asked me a question. Here we go. Thank you, Madam Chair, for the opportunity to present SB 305. I know that the time is going away from us quite quickly, so I'm going to be brief in my comments as I introduce the bill, and then I'll have Rachel Chesson, she's the one who brought this to my attention, and she would like to do a small presentation. I have informed her to keep it brief, and then we'll move on to questions. So basically, I'd like to go over just a little bit of SB 305, probably 4 things that it does and 1 that it does not do. Number 1, this bill prohibits certain providers of medical or related services from taking certain actions relating to organ transplants solely on the basis of a person's disability. 2, it also authorizes a person aggrieved by the failure of such a provider to comply with certain requirements to institute a civil action for injunctive or other appropriate relief. 3, it extends those prohibitions or prohibits an insurer from taking certain actions related to an organ transplant because the insured is a person with a disability. And then fourthly, the 4th thing that it does is it also prevents a provider of healthcare services from not just putting somebody with a disability on a list, but it also prevents them from putting on a list, but putting them on lower on the list because of that disability. What it doesn't do is it does not take away a physician's ability to diagnose a patient and determine whether or not that patient is eligible or is a good fit for a particular transplant, an organ transplant. So what we're trying to do here is we're trying to make sure that folks with disabilities, whether it's intellectual or cognitive or whatever, that they are not denied an organ transplant because of their disability. And so, again, I'd like to introduce, I think she's still on there, Rachel Chesson, who has spoken about this several times, but she brought this to my attention. So with your permission, Chair, I would like to turn the time over to Rachel Chesson.
Hello.
Hello, Ms. Chesson, welcome.
Hi, good evening, Madam Chair and members of the committee. Thank you so much for allowing me to speak, Senator Hammond. My name is Rachel Chesson, and I am so excited to be here in support of Caleb's Law, SB 305. I'm going to go ahead and just share my screen real quick, just 1 second. Great. I think I am good to go here. Again, my name is Rachel Chesson. I'm presenting Caleb's Law, Nevada SB 305. Caleb's Law is an act relating to healthcare, prohibiting certain providers of medical or related services from taking certain actions relating to organ transplants solely on the basis of a person's disability, limiting the extent to which such a provider is authorized to consider a person's disability when making recommendations or decisions concerning an organ transplant, requiring such a provider to take certain actions to provide a person with a disability access to any service provided by the provider related to an organ transplant. Authorizing a person aggrieved by the failure of such a provider to comply with certain requirements to institute a civil action for injunctive or other appropriate relief, prohibiting an insurer from taking certain actions related to an organ transplant because the insured is a person with a disability, and providing other matters properly relating thereto. Just some background on me and Caleb's Law and why I brought it to Senator Hammond's attention. I'm a born and raised Las Vegan, the community engagement director at a local nonprofit here in town called the Just One Project, and I'm a fierce disability advocate. I share our journey online via Instagram and our blog, A Little Extra Love, and I'm truly blessed. But I'm here because I'd really like to tell you about my amazing son, Caleb. He is happy, healthy, and 22 months old. He goes to preschool part-time here in Vegas, hangs out with his grandma a couple days a week, and he's learning sign language. He loves going to the park with his friends, and he's also quite the little model, participating in brand campaigns, emphasizing inclusion in the community. He's a bit of a social media star with 10,000 followers. You should definitely check him out. He's a good follow. I like him a lot, but Caleb also happens to have Down syndrome, trisomy 21, or what I like to call his extra love that makes him exactly who he is. Because of his diagnosis, I have been an active member of the disability community for a couple years now. And within the community, I heard some stories that totally changed my life and stood out to me, and were almost unbelievable. The first one I heard was a story about a little girl named Ellie. She wasn't even a year old, living with her family in Ohio and in need of a heart. The doctors told Ellie's mom Ellie wasn't eligible for a heart transplant, not because she was too sick or because of any medically significant reason. She wasn't eligible for a transplant simply because she had Down syndrome. That was it. The doctors in her case determined that because she had an intellectual disability, her life was not worth saving because of an extra chromosome. When I heard Ellie's story, I immediately assumed that it must have been an anomaly, a one-off, some type of doctors acting outside of standards of care. But what I found was so much worse. From a simple Google search, story after story, a 10-year-old boy named Leaf in Oregon denied a transplant because he has autism. Amelia, a 3-year-old, denied a kidney in Pennsylvania. 5-month-old boy named Maverick denied a heart in New York because of another rare chromosomal disorder similar to Down syndrome. And that's when it hit me. My son Caleb, who is perfectly healthy now, no medical concerns to speak of other than some trouble from being born premature, that he has now grown out of. And if he needed an organ tomorrow, it would be because of an accident or trauma. It would have absolutely nothing to do with his diagnosis of Down syndrome. Yet studies show 85% of pediatric transplant centers would take Caleb's intellectual disability into an account. 71% of heart programs indicate that even mild or moderate cognitive impairment is enough to disqualify him from the organ transplant list. And the survey showed that transplant centers always or usually consider ID-DD diagnoses when deciding eligibility of transplantation. And 52% of people with ID-DD receive a referral for a specialist evaluation, and only 33% of those 52% who are referred are never evaluated. So story after story, it recently happened again. Just in February of 2019, the University of North Carolina was forced to resolve an investigation by the U.S. Department of Health and Human Services after they denied someone a heart transplant simply because he had a learning disability. And when their actions were challenged, UNC immediately reversed course with DHH issuing this statement. The director of the Office of Civil Rights, Roger Soverino, said, and I quote, "Every life is precious and no one should be blocked from access to an organ transplant because of stereotypes about persons with disabilities. It is also against the law." And that's an important point, and the reason why I'm here today is for support to ban organ transplant discrimination here in Nevada. But we are not asking the state to do anything new. We're not asking them to reinvent the wheel. Discrimination in medical services is already illegal under the Federal Americans with Disabilities Act. The problem is enforcement. There's no way for you or me to enforce the ADA because it has no mechanism for enforcement. So in practical terms, that leaves us, the state of Nevada, on our own to not just prevent discrimination, but to give people an effective way to challenge discrimination when and where it happens. And that's where Caleb's Law comes in. Caleb's Law clarifies that doctors, hospitals, transplant centers, and other healthcare providers are prohibited from denying access to necessary organ transplants solely on the basis of qualified individuals' disability. It requires that health providers consider in evaluating the likelihood of transplant success the full range of supports available to help a person with a disability manage their post-operative care, and it includes a fast-track procedure for challenging discrimination to ensure that people in urgent need of an organ transplant can obtain timely resolutions to their claims. And the best news is I've already reached out to doctors all over the state, the heads of multiple transplant centers throughout the country, and even the American Heart Association and the Children's Heart Center of Southern Nevada and Opportunity Village. And I'm pleased to say today I've not heard one word of opposition to this bill. None. Overwhelmingly, even from the medical community, the response seems to be one of understanding. This is a bill that represents a significant step forward in the protection of people with disabilities in the state of Nevada, and it should be passed. And one last thing, because I know I've already taken up too much of your time, 15 states have already passed laws similar to this, and another 13 have similar bills pending in 2021. In almost every instance, though, those bills were proposed because someone with a disability was in a desperate and immediate need of a life-saving transplant and was facing unfair discrimination. It's my hope that we don't wait for a similar story here in Nevada. It's my hope that you can support us in passing Caleb's Law, SB 305. Thank you guys so much for your time.
Thank you, Ms. Jessen. You are absolutely not taking up too much of our time. We very much enjoy hearing from moms who are fighting for their kids and everybody else's kids. So thank you for spending your time with us this afternoon, or I guess now evening. Committee members, any questions? Senator Hardy.
Thank you, Madam Chair. It was a little unclear to me, and maybe I just couldn't read it. Are disabled people or people with a disability able to donate an organ?
Thank you, Senator Hardy, for that question. This is again Senator Scott Hammond. I don't know the answer to that question, and I don't know if Ms. Cheston has an answer to that question either. But I certainly let her take a shot at it. Are they able to?
So this bill specific is for those who are needing an organ transplant, not wanting to donate. So this really doesn't have anything to do with donations.
And I don't know if we have anybody from DHHS that would know enough about the donation side to be able to answer that question. If you feel like that, I suspect when we get to public testimony, perhaps there may be some of the organ donor organizations here today, so one of them may be able to answer the question at that time.
And again, this is Senator Hammond. I believe you're correct, Madam Chair. I think that there's going to be a few who are on the phone who will be testifying, and I think they would be able to proffer an answer for you.
Any additional questions, Senator Hardy? Okay. Any other questions from the committee members? It's a pretty straightforward bill. All right, so let's go ahead and open up the testimony from the public on SB 305. If you are there and would like to testify in support of SB 305, we'll open the lines now.
Thank you, Chair. Callers, if you'd like to testify in support of SB 305, please press *9 now to enter the queue. Will the caller with the last 3 digits of 900 please slowly state and spell your name for the record? You'll have 2 minutes and may begin. If you're having trouble unmuting yourself, you can press *6.
Thank you, Madam Chair, members of the committee. Dan Musgrove here today on behalf of Nevada Donor Network. I'd like to apologize to Senator Hammond and Rachel. Joe Fiera, the CEO of Nevada Donor Network, had to get off the line. He was on earlier, but I'm taking his place, and I unfortunately cannot answer that question regarding whether the disabled can be a donor. I have texted folks, and I will try to get that answer. But I just wanted to, again, thank Senator Hammond and Rachel for bringing this. Nevada Donor Network has the distinction of being the most productive and successful organ procurement organization in the world based on our population size that we serve, primarily because of how inclusive we are as an organization. And sadly, 20 people die each day in the United States awaiting the gift of life, which never comes because of the shortage of organs available for transplantation. And so among those who perish every day are those most vulnerable citizens who must be assured an equal chance at life and health, regardless of whatever disability they may have. And so with that said, we are absolutely in support of this bill. And I did, in fact, get a text back, and the answer is yes. Typically, the caregiver of that person can authorize someone who is disabled to be to give that fabulous donation of life, the gift of life. So thank you so much, Senator. We are in support.
Will the next caller with the last 3 digits of 993 please slowly state and spell your name for the record? You may begin now.
Hi, good evening. This is Brittany Perkins, BRITTNEY PERKINS. Madam Chair and committee members, it's my pleasure to testify today on behalf of proposed Senate Bill 305 and to express my full support for the passage of this bill and share my personal testimony regarding how this bill affects my family. I am a resident of Henderson, Nevada. I'm an attorney, and most importantly, I'm a very proud mom. On October 3rd, 2019, my entire world stopped for 6 grueling hours while my 4-month-old daughter was on the operating table at Sunrise Children's Hospital on bypass while an extraordinary surgeon, who I have dubbed Superman, repaired her broken heart. My daughter was born with 1 sweet dimple and 10 fingers, 10 toes, 2 beautiful almond-shaped eyes, a hole in her heart, and 47 chromosomes. And depending on who you ask, this extra 21st chromosome and what it brings, also known as Down syndrome, it may lead to her having mild cognitive delay or perpetual happiness. But because of her genetic makeup, if her heart repair had been unsuccessful, she could be denied a heart transplant due to this genetic condition that has no bearing on the functionality of that transplant. No parent should have to sit those grueling hours in that stark hospital waiting room while their child is having surgery and simultaneously shoulder the burden that, should the procedure not be effective, should their child require an organ transplant, that they might not get one because their child wears the title of disabled. These individuals were somehow deemed less worthy of these life-saving measures, and I am hopeful that this stops today. Times have changed and society has evolved, and my daughter is entitled to the benefits of the Equal Protection Clause and enforcement of the ADA of our federal government. There is no place left in this state for organ transplant discrimination. We often think a law is just a law, but until your child's life depends on it, takes on a new meaning. My child's life is worth living and saving. Thank you.
Thank you for taking the time to share your story with us.
Will the next caller with the last 3 digits of 838 please slowly state and spell your name for the record? You'll have 2 minutes and may begin.
Hello, my name is Candace Wong, CANDACEWONG. I'm a registered nurse here in Nevada, have been for the past 12 years, been a nurse for over 20 years. I have a 5-year-old daughter who was born with trisomy 21, which most of you know as Down syndrome. She is a 5-year-old who communicates with her peers, who's in an all-inclusive program, who loves to rock climb, who loves to ride her bikes and her scooters, is active in every activity that all of us partake as a family. She's also active in the community, helping with picking up trails at Mount Charleston, Red Rock, and also too in the Henderson area. We also, every year for their birthday, she's a twin. So there's actually, I'll talk to a lot in day because she is a twin. And they also, every year for their birthday, collect food and donations for 3 Square. And we also do walks throughout the community to help out multiple organizations here in our local area and help raise awareness. So my daughter, at the small age of 5 years old, has already made an impact with her fellow peers within her school, within her community, and absolutely within their home. She's definitely entitled to the same benefits as her twin sister, who does not have trisomy 21. Both of them were premature at 29 weeks, weigh less than 3 pounds. My daughter was born with cerebral atresia and had to have a surgery. She had a 5% chance of survival through the NICU, but here she is today, thriving and meeting all the pre-K standards, the same as all of her peers. Every individual is different. Every individual
has different medical concerns and different conditions, but each one of those should be evaluated prior to denying or accepting transplantation. And yes, a person with a disability, along with Down syndrome, can donate and have donated as long as they give their permission. They also vote, they work. They're so progressive now because we have resources available to assist them to be a part of the community. This isn't a time where we were way back when they were institutionalized and forgotten. They are here and they will continue to be a part of our community. I want to thank all of you who put this bill together as part of the medical profession to assist with actual transplantation and those services. And we just thank you for taking a look and ensuring that all members of the community are treated equally. Thank you.
Thank you for your testimony.
If there are any more callers who wish to testify in support of SB 305, please press *9 now to enter the queue. Chair, at this time, no other callers have indicated that they wish to testify in support of SB 305.
All right, let's go ahead and move to opposition for SB 305.
Certainly, Chair. Callers, if you'd like to testify in opposition to SB 305, please press *9 now to enter the queue. Chair, at this time, no callers have indicated that they wish to testify in opposition to the bill.
Thank you. Let's go ahead and open up the testimony in neutral. Mr. Young, are you here to testify in neutral?
Yes, I am.
Please go ahead.
Thank you, Chair Ratty. Dwayne Young, Deputy Administrator for the Division of Healthcare Financing and Policy for the record. We just want to put on the record that this is good public health policy. However, the division does request a friendly amendment. The language says must go into the state plan. That is our contract with CMS. And this language would be best in our Medicaid services manual. That way it would hold all providers and partners of Medicaid accountable to the language in this bill. Thank you.
Thank you. EPS, if you would open up the line for neutral.
Thank you, Chair. Callers, if you'd like to testify in a neutral position for SB 305, please press *9 now to enter the queue. Once again, if you'd like to testify in a neutral position for SB 305, please press *9 now to enter the queue. Chair, at this time, no callers have indicated that they wish to testify in a neutral position for SB 305.
Great, thank you, BPS, for your help again. First of all, Senator Hammond, from our legal counsel, we did get an answer to the question to confirm. So Mr. Robbins says, based on NRS 451.556, it appears that people with a disability can donate under the same circumstances as anybody else. So no discrimination in the law there. Closing comments, and if you could, for the record, let us know your thoughts on the friendly amendment, or the proposed amendment, if it's friendly. Thank you.
Thank you, Chair, and thank you again to the committee for allowing us to present the bill. A lot of the work has been done by Ms. Chesson, and I can't tell you how honored I was to be in her presence and meeting. I met her son and saw how passionate she and others who you heard tonight testify on behalf of the bill are about this particular issue. I am amenable to the change to the amendment that was proposed by Mr. Young. I think that it fits in with what we're trying to do. It just makes sure that it's in the right place, and I'm okay with that. And also, while we were waiting, my legislative assistant, Julie, also happened to come across an article, and I'll just quote a part of the article and then end my testimony here. It basically is an article from January 2020, and it just says, every second counts when a sick child needs an organ transplant, but parents of people with disabilities may need years to get their children on the list. People with disabilities can be organ donors. They can give all their organs. There's no law against it. But if someone with a disability needs an organ transplant, that fact alone can get them removed from the list. And I think that we want to try and, in a time when we're all trying and equal things out, this is a bill that seeks to do that, bring that sort of equality to the disability community. And I'm grateful for the opportunity to present, and I'll close my statement with that.
Great, thank you. With that, we're going to close the hearing on SB 305. Again, thank you, Ms. Justin, for spending your evening with us. And we will go ahead and open the hearing on SB 329. Well, first, let me double check. Senator Lang, do you have the presenters that you need for SB 329 still on the line?
If I can unmute. Yes, I do.
Okay, great. So with that, we will open the hearing on SB 329 and turn the dais over to Senator Lang.
Thank you, Chair Ratty. We and committee members, we really appreciate you keeping the committee going so that we can have the opportunity to talk to you about this bill. It aims to enhance transparency around healthcare consolidation and limit anti-competitive contract practices between hospital systems and health insurers in Nevada. Before I begin, I just want to make sure that you all knew that there was an amendment and it should be with your papers, and if not there, it is on Nellis. Let me just quickly tell you about the problem. As you are aware, healthcare spending is high in Nevada and nationwide. According to official estimates, total healthcare spending in the United States reached $3.8 trillion in 2019, a 4.6% increase from the previous year. In fact, national health spending has been growing by 4 or 5% annually since 2014. One factor that contributes to high healthcare spending is market consolidation. According to the Kaiser Family Foundation, a large body of research demonstrates that consolidation of healthcare providers leads to a higher healthcare prices for private insurance. In 2020, the Medicare Payment Advisory Commission reviewed available research on hospital consolidation and found that the preponderance of evidence suggests that hospital consolidation leads to higher prices. An analysis of 25 metro areas with the highest rates of hospital consolidation between 2010 and 2013 found the price of private health insurers paid for the average hospital stay increased between 11 and 54% in the years after consolidation. Another analysis found that prices in hospitals without competitors in a 15-mile radius were 12% higher than hospitals in markets with 4 or more competitors. In addition, studies of the impact of hospital mergers found the average price increases between 6 and 9%, regardless of whether the hospitals were for-profit or nonprofit. Studies also show that consolidation of healthcare facilities reduces the ability of health insurers to keep prices low because they have less market power than hospitals. Nevada currently does not have many tools to review or regulate consolidation in the healthcare market. We have a pretty high bar before mergers and acquisitions are reviewed by state agencies. Certificate of need laws only apply to certain parts of the state. We do not have any information about the impact of private equity in healthcare markets, and nothing prohibits contracting practices that favor healthcare monopolies. This bill aims to address these problems by taking the first step to monitor consolidation among healthcare facilities and limiting anti-competitive contracting practices in contracts between hospital systems and health insurance payers in Nevada. I'm going to introduce my speakers. But before doing that, I'd like to say, in the interest of time, they'll do their presentation, and then when we address questions, please address them to the experts. Joining me to provide additional information regarding the real-world effect of these issues, as well as to discuss the technical details of the bill and amendment, are Stacy Sasso, Executive Director of Health Services Coalition, Maya Holmes, Healthcare Research Manager for the Culinary Health Fund, Babette Bond, Director of Public Policy for the Culinary Health Fund, Katie Gudenson, Senior Health Policy Researcher for the Source on Healthcare Price and Competition. With your permission, Chair Ratty, I'll turn it over to the experts.
You know, I've never actually said no to anybody when they ask that question these days, but I'm not going to do that to you today, Senator. So
okay.
Let's go ahead and go to your presenters.
Thank you.
Good evening. For the record, I am Stacy Sasso, Executive Director for the Health Services Coalition. We want to thank Senator Lang for bringing this needed bill forward and working with us on the conceptual amendment to meet the intent of the legislation while streamlining the language and process. We'd also like to thank Chairwoman Ratty, Vice Chair Spearman, and the committee members for their consideration of SB 329. The Health Services Coalition represents 25 employer and union-sponsored health plans in Southern Nevada, including MGM, Boyd Gaming, firefighters, and police, as well as numerous self-funded union plans, including culinary, electrical workers, plumbers, and various other groups. The coalition's main focus is to bring affordable quality health care to our estimated 300,000 lives in Southern Nevada. I'd like to turn the presentation over to Babette Bond.
Thank you. Thank you, Chair Ratty and members of the committee. And again, thank you for hearing this bill. And thank you, Senator Lang, for bringing the bill forward. For the record, I'm Babette Bond, and I'm the Policy Director for the Culinary Health Fund. We're a nonprofit fund that provides comprehensive benefits to 125,000 people in Las Vegas. We have 2 pharmacies and a large primary care center that had 40,000 visits the year before COVID started. So we're a piece of the healthcare market here. And our priority, our focus is on high quality, affordable healthcare and how to get there. We are aggressive about trying to be effective stewards of both private and public monies for the state of Nevada. As Senator Lang already outlined, there's an increasing consolidation in the healthcare industry, healthcare hospital systems buying other systems, private equity buying up doctor groups, and experts expect that trend to only continue with COVID because of the impact that COVID has had on the healthcare industry. We know consolidation is happening in Nevada and our markets are already impacted, but we don't have any line of sight into the impact of consolidation and its impact in Nevada yet. Price is the primary factor behind our US high healthcare costs and compared to other nations, and consolidation and lack of competition is a critical factor in healthcare prices. If we could go to the next slide. Oh, perfect. Okay. No, back one. Sorry. Thank you. Perfect. All right. So prices in healthcare have increased much faster than inflation. Hospital prices in the US have increased a staggering pace over the last 20 years, outstripping college tuition on this chart, outstripping wages, and outstripping housing. According to CMS, hospital prices rose 3 times the rate of inflation between 1960 and 2016. So that's a snapshot of how dramatically it's impacting us. Next slide. And this is what it looks like at the grocery store. So if prices did the same thing in the food market, you'd pay $57,000 for $57,000, that would be bad. $57 for oranges, $65 for 12 eggs, or $160 for a gallon of milk. Next one. All right, there's 2 kinds of consolidation. There's 2 kinds of industry consolidation we're talking about. One is horizontal consolidation. That's when in the industry, one facility buys another facility that's like it. They're the same place in the healthcare market. And that is a hospital to hospital thing often. Studies repeatedly show that this kind of consolidation results in higher prices without improving quality, which is the thing that we're interested in talking about here too. Academic researchers found post-merger hospital prices increased 20 to 44%, and they were not associated with improved quality. It was modestly worse patient quality and patient experience. Next slide. The other kind of consolidation is vertical. That is when one industry higher in the healthcare chain purchases or absorbs one lower. That's when a hospital or purchases a physician group, or when a large physician group would purchase a specialty group. That's when they're vertically integrating. When hospitals and physician groups merge, a recent study shows over 4 years, 32 to 47% increase in prices. Again, no quality improvements. So in the last 5 years, there's been $10 billion worth of consolidation, private equity money alone, coming into the healthcare market and buying medical practices. And again, in Nevada, we know it's happening. We have personal experiences of it because we get to see contracts, but we don't have any line of sight policy-wise to see the system in Nevada, and that's what this bill's about. Private equity playbook in most industries is to leverage the debt to buy the company, then cut costs, and then sell at a profit within 3 to 5 years at an annualized rate of return of between 20 and 30%. So it's not like buying cars, because this is people's health and people's lives. And it's when it becomes a monetary transaction, then we're losing all the things that healthcare needs to have. State and federal authority exists to protect competition and stop unfair practices that hurt competition. But healthcare deals fall below the radar, especially in Nevada. It takes a lot. It takes a really high level of an integrated merger in order for us to see it. And increasingly, states are looking at other ways to get their arms around understanding what's going on with competition and to try to protect the healthcare market and keep it healthy and competitive. I'm going to go to Maya Holmes, and I appreciate the time. Thanks so much.
Thank you. So for the record, my name is Maya Holmes. I'm with the Culinary Health Fund. SB 329 will ensure that Nevada has accessible data on what is happening in our healthcare markets to protect healthcare competition. This information is really critical for the state, for policymakers, patients, payers, and other stakeholders to, one, just understand consolidation in our healthcare markets and really guide decisions that protect competition and patient choice. And two, it will ensure that we address market players who are trying to use their market power to drive up prices and thwart competition based on price and quality. So the bill proposes prohibiting anti-competitive contracting practices that hospitals and healthcare providers with market dominance can demand because payers have to have them in their markets. There was recent settlements in 2 major antitrust lawsuits. There was one in California involving the Sutter Health System and another in North Carolina. They ended many of these anti-competitive contracting practices. However, the settlements do not set legal precedent, and they only apply to the health systems involved in the lawsuits, which were major multi-year lawsuits. Anti-competitive contracting practices like all or nothing and anti-tiering, these practices prevent health plans from directing or incentivizing patients toward lower cost, higher quality care. And these provisions also prevent other hospitals from benefiting if they offer better deals or higher quality. They also stop patients and health plans from shopping for and getting the best deal. We're really pleased to have been able to work with Senator Lang on a conceptual amendment to SB 329 to really simplify and streamline the bill's provisions. And we're still working with her on some of the language involving self-funded plans, but that work will not change the substance of the amendment and how we're proposing it would affect the bill. So as a result of the conceptual amendment, the bill will have 2 primary provisions. First, the bill will require reporting on healthcare deals involving hospitals and physician groups 60 days after they have occurred. And it would essentially require basic kind of summary information would be reported, and that information is listed in the bill. So I wasn't going to walk through that here. The other piece of the bill, and this is in section 1 of the original bill, the conceptual amendment just suggests a few changes, but not the overall substance. But the other piece of section 1 would be the bill requiring DHHS to post the information contained in the notices on an internet website maintained by the department. We think this is important for transparency. Connecticut has done this for several years. DHHS would also prepare an annual report regarding market transactions and concentration in healthcare based on those notices, with the summary information of the transactions after they've been done. And then they would post the report on an internet website maintained by the department. The bill's other major provision would make specific anti-competitive contract provisions unfair trade practices, and those prohibited provisions would be void and severable. The specific contract provisions between hospitals, health systems, providers, and health plans that would be prohibited as an unfair trade practice are anti-tiering and anti-steering clauses. These clauses essentially require health plans to place all of a health system's hospitals in the most favorable tier with the lowest cost sharing, regardless of the rates they are charging or their quality. The other anti-competitive provision that would be prohibited would be all or nothing contracting. These are clauses when a health system demands that an insurer include all the system's facilities in their network, regardless of whether a plan needs the facilities for their members, if it drives up healthcare costs, or is a lower quality facility. Now I'd like to turn the presentation over to Catherine Gudikson to discuss what is happening in other states.
Hi, my name is Catherine Gudikson, for the record. And before I start, I just have to make the disclaimer that any opinions or statements I make today are all my own. They don't represent the views of my employer, the University of California, Hastings College of the Law, the Source on Healthcare Price or Competition, or our funders. In the interest of time, I think I'll just be very brief and say that there are 7 other states, so Nevada plus 7 more, that are considering very similar bills this session to ban particular contract terms, any tiering, any steering, or all or nothing contracting. You can see them there. And they all do similar things. They make these unfair trade practices and ban them in those contracts. The federal government also considered similar language last session, but it didn't get through Congress at the end of last session. The Lower Healthcare Costs Act of 2019 would have banned these provisions as well for all plans. And I think I'm happy to answer specific questions, but in the interest of time, I don't think it makes sense for me to walk through all of these bills. Do I pass it back to you, Maya? Thank you, Ms. Gudikson, and thank you for not walking through all of those bills with us.
I think
additional part of the presentation?
Senator Ratty, we'd be happy to take questions from the committee.
Fantastic. So I will open it up to the committee for questions. Senator Hardy.
I look at this perhaps through different lenses. The narrow networks seem to me to be anti-competitive. So the physician that it's alluded to in the digest, the physician can't enter a contract that has certain provisions that restrain the ability of an insurer to contract with other providers of healthcare. So is this going to create more of a narrow network, but not allow a narrow network to happen?
Should I answer that one?
Yes, please.
Catherine Gudikson, for the record. This bill would allow insurers to develop narrow networks, so that would be another option. Many of the large health systems require their inclusion in a network. So it's very hard for insurers to steer patients toward higher value, higher quality care.
And so this bill would prevent that. It doesn't prevent insurers from creating narrow networks or from physicians from entering narrow networks.
It also doesn't encourage them, though. It's not about narrow networks. I think what it's about, I'm sorry to interrupt. I think what it's about.
Ms. Bond, if we could just get your name on the record.
Yeah, thank you.
To be able to keep track.
Bobette Bond for the record. I think specifically what we're trying to do, Senator Hardy, is make sure that patients have the ability to use their copays, their deductibles, their part of the healthcare cost to go to the facility that has the best quality. Even though it's actually the opposite of what you're suggesting. We have large networks and we want to keep all the doctors and hospitals contracted that we have, but we want patients to have more ability with their own dollars to go within that network to the place that has the best quality and not be prohibited by contract to do that.
Well, it sounds like narrow networks. Thank you.
Thank you, Senator Hardy. Additional questions? Senator Harris.
Thank you so much, Chair Ratty. I don't know who the legal beagle is of the presentation, but I know the Attorney General here in Nevada has some kind of plenary powers to pursue deceptive and unfair practices. Can you talk a little bit about why those powers aren't sufficient to address this type of anti-competitive behavior?
I can try. Maya, you might have to follow up with me again for the record, Bobette Bond, if this is okay with you, Senator Lang. Mm-hmm. There is actually another bill in this legislature to try to deal with some of this, but frankly, what we've heard from the AG's office, Senator Harris, is they're not really in the business of making any of this information public. And I think for public policy reasons and to understand the ecosystem and the market, we need it to be public. So first of all, they only handle issues at a very, very high dollar threshold, something like United Health merging with Sierra Health Services. That got a lot of AG action, a decade ago. But things like this, where you have one hospital buying another hospital or private equity in the market buying in small chunks, the AG's office doesn't see it at all. And what they do see, they don't do anything with public reporting, and that's what we're trying to get to.
Okay, thank you.
I was just going to add on, this is Maya Holmes for the record. I think the other piece is a lot of the contracts are opaque, and so people don't know, they're confidential, they don't know what's in those contracts. So this is making it very explicitly clear that these are prohibited transactions under the Unfair Trade Practices Act.
Additional questions? Senator Kiekhaefer.
Thank you very much, Madam Chair. So I'm looking at the amendment. Can you explain to me, because I do not understand, what is meant in paragraph 3 of subsection 7 regarding placing all members of a healthcare provider in the same tier of a tiered network plan?
Should I take that one again? This is Katie Goodixon for the record. So when insurers want to use tiered networks, they often divide a range of providers into different tiers with different cost sharing. So for example, the highest value or highest quality, often these tiers are based on quality. They'd put the highest quality providers in one tier with the lowest cost sharing so that there would be some incentive for patients to choose those. And the large health systems with multiple, if you have a hospital and an MRI clinic and a lab, there are some health systems contractually require all of them to be placed in the highest value tier, even if they wouldn't meet those quality or cost standards on their own. So this would just allow an insurer to divide providers based on quality to the different tiers or whatever standards they have for placing providers in tiers.
Would providers place multiple or different doctors within the same practice within different tiers?
Typically not. Typically, they're different facilities. That would be in the network laws. The one state that has this in law is Massachusetts, and they very clearly have restrictions on how the tiers are divided, and they typically are by facility. So for example, a group practice would all be in one tier, but the hospital itself might be in a different tier. The MRI, the outpatient clinics might be in a separate tier.
So, I guess I understand we have a for-profit healthcare system, right? That's it currently exists. I know a lot of people don't like it, but these are business negotiations and contracts that take place between two private entities, and to even ask for a provider to even ask to be put into a specific tier, or that other people should be put in the same tier, that a mutually owned practice would have to be contracted with, should be a deceptive trade practice. I mean, is that really where we want to go?
For the record, Bobette Bond, Senator Keycupper, I think where we want to go is not prevent us, our benefits and our members from being able to have healthcare move towards high quality and high value because a contract is required, because the provider has monopoly level control over the market. So there's a requirement to serve your members that you're contracting with them, and we want to, but not let that be prohibitive from also having incentives that are able to use other providers. And there are contracts that don't allow it.
And I would, sorry. I was just, Maya Holmes for the record. I was just going to add that having the, where it comes into being anti-competitive is because, as Bobette said, when you have a market player who's using their market dominance, their monopoly payer, they're basically preventing other providers, other facilities from being able to compete on the basis of price and quality, because that dominant provider is saying, I can be in the same tier, even though I charge more and I have lower quality, but I'm just basing that on, I'm so large, you have to have me in my network and I can demand that.
And then the retro, I mean, what you mean by Section 8 is, or subsection 8 there, is that any currently existing contract is void that contains any of the above provisions?
Bobette Bond, for the record, not the contract, just that section of the contract. Just that language that is the monopoly language. The rest of the contract stands.
I disagree with the characterization of monopoly language, but
okay.
Thank you.
Thank you, Senator. Okay, Committee, do we have any additional questions? Okay, seeing none, we're going to go ahead and go to public testimony. I'd like to open up public testimony for this bill. BPS, please help us out.
Thank you, Chair. Callers, if you'd like to testify in support of Senate Bill 329, please press *9 now to enter the queue. Will the caller with the last 3 digits of 796 please slowly state and spell your name for the record? You'll have 2 minutes and may begin.
Thank you, Madam Chair, members of the committee. For the record, Rusty McAllister, RUSTYMCALLISTER. I'm the Executive Secretary Treasurer for the Nevada State AFL-CIO, representing 150,000 plus members and their families, which make up hundreds of thousands of these insured people in Southern Nevada. Madam Chair, we believe and we support this bill because we believe that the reporting notifications regarding buyouts and mergers, these notifications are essential to our members' health plans. You know, a lot has changed just in the last 5 years. Mergers and buyouts are becoming more of a regular practice, and private equity is found that this is a great market to jump into. As a matter of fact, there's 2 emergency room groups in Southern Nevada that are now owned by private equity. One of them, in fact, tried to terminate the contract or run out a contract of emergency room simply for the idea that they could raise the rates. These notifications will help our funds to better advise our members and to control the cost, the limited amount of dollars that we have, control the costs. For that matter, Madam Chair, for the other thing that we are certainly supportive in this language is that the language that keeps providers of healthcare from having contracts that limit our members and our plans from being able to seek out the best and most cost-effective treatments are important. That's important to our members. The language in these contracts creates a monopoly scenario, and that's not good uses of our limited healthcare dollars. For those reasons, Madam Chair, we are, and members of the committee, we are in support of this legislation. We try and keep our contracts and networks as open as possible. We've contracted with every hospital network in the Southern Nevada. We have huge provider networks, but we have groups coming in and trying to limit that, and purely for profit, purely to rake us. So with that, Madam Chair, we're in support of this legislation. Thank you for your time.
You bet. We'll stay in testimony for support on SB 329, but I'll ask folks to limit their testimony to 2 minutes.
Will the next caller with the last 3 digits of 598 please slowly state and spell your name for the record? You'll have 2 minutes and may begin.
Hello, my name is Justin Larson. It's JUSTON LARSEN. I am a furloughed Starbucks barista from the airport and a culinary union member. I've had asthma for as long as I can remember. I carry an inhaler everywhere I go, just in case I have an asthma attack. I want to be informed and empowered patient, so I need to have information to be able to be better advocate for myself. I trust my culinary health fund to help make sure I'm going to the best quality of care for the lowest price. I wish that my culinary health fund advocate could give me advice on which place is best for me to go. A place that is safe, a medical professional that is a good doctor, and a clinic that is the lowest copay for me. But right now, due to anti-steering and anti-tiering language in hospital contracts, my culinary health fund is not able to give me the complete information that I need and deserve. And that is not right. Removing anti-competitive clauses from hospital contracts will allow my culinary health fund to better give me the complete information so I can get my health needs met better. Thank you for listening, and I rise in support of SB 329. Thank you.
Thank you.
Will the next caller with the last 3 digits of 018 please slowly state and spell your name for the record? You'll have 2 minutes and may begin.
Good evening, committee. My name is Jim Sullivan, JIMSULLIVAN, and I'm representing the Culinary Union. The Culinary Union supports SB 329 because healthcare affordability, quality, and access are critical concerns for Culinary Union members. Consolidation in the healthcare industry drives up the prices, but not the quality of our healthcare. SB 329 will take important steps to understand how consolidation impacts our healthcare markets. In addition, SB 329 will stop anti-competitive contracting practices that prevent patients, employers, and plans from shopping for and getting the best deal. The Culinary Union urges the Nevada Legislature to support and pass SB 329. Thank you.
Chair, at this time, there are no more callers in the queue for support of SB 329.
Okay, let's go ahead and move to opposition on SB 329.
Certainly, Chair. Callers, if you'd like to testify in opposition to SB 329, please press *9 now to enter the queue. Will the caller with the last 3 digits of 020 please slowly state and spell your name for the record? You'll have 2 minutes and may begin. It looks like you're muted, caller, so you can try to press *6 to unmute yourself.
My name is Jim Wadhams, WADHAMS.
tonight on behalf of the Nevada Hospital Association. We appreciate Senator Lang offering to discuss this bill with us just yesterday, and we're presented with an amendment which substantially altered the original bill. The Hospital Association members have not had a chance to review this fully, and although we are in opposition, we have committed to Senator Lang to continue to work with her and any other stakeholders on this bill. However, at the moment, because of that opportunity we have to appear in opposition. Thank you.
Will the next caller with the last three digits of 018 please slowly state and spell your name for the record? You'll have 2 minutes and may begin.
My name is George Ross, George Ross, appearing on behalf of HCA Healthcare. Madam Chair, members of the committee, as the bill is currently drafted with a conceptual amendment, HCA strongly opposes the bill. This bill would necessitate separate contracts for each hospital, each ambulatory surgery center, each urgent care center, with very dangerous for patient care. We have carefully developed a system of care over many years with linked protocols and IT systems critical to organizing and coordinating care to get the right, most effective treatment for a person at exactly the right time. This particular bill, as currently existing, would, with the amendment, would fragment care, it would risk the duplication of services, it would disrupt relationships, end value-based contracts, and most likely raise costs. I'd like to clarify that when hospitals, at least when HCA contracts with doctor groups such as ER groups, those are not exclusive contracts. Those doctor groups are free to contract with any other group they choose. In addition, essentially one could argue very strongly that the only limit on an individual patient of shopping around for the best deal and the best doctors of the terms of his own insurance plan. His out-of-network penalties, his co-insurance, his co-pays. The limitation is the narrow networks, as Dr. Hardy pointed out. It's not the providers or the hospitals. Thank you. We are willing to work with the sponsor through the Nevada Hospital Association, but at this point we have to oppose this bill strongly. It will have a major impact on both quality and access to care in the state of Nevada.
Thank you.
Will the next caller with the last three digits of 900 please slowly state and spell your name for the record? You'll have 2 minutes and may begin. Once again, caller with the last three digits of 900, please slowly state and spell your name for the record. You can press *6 to unmute yourself if you're having trouble, and you may begin now with 2 minutes. Looks like that caller's having some technical difficulties. Chair, we'll circle back to them. Will the next caller with the last three digits of 122 please slowly state and spell your name for the record? You'll have 2 minutes and you may begin.
Good evening, Chair Ratty, members of the committee. For the record, my name is Katie Ryan, K-A-T-I-E-R-Y-A-N, and I am System Director of Nevada Government Relations for Dignity Health St. Rose Dominican. I wanted to quickly call in opposition to both the original version of SB 329 and the conceptual amendment for the reasons already cited by my colleagues. This bill is duplicative of AB 49, which we've been working on with the Attorney General's office around reporting of healthcare transactions. Also, the contracting restrictions piece of both the original version and the conceptual amendment is problematic and will make navigating healthcare coverage even more difficult for patients, while also creating access to care and quality issues by interrupting the continuity of care. We are also willing to work with the sponsor of the bill on this, including, with the Nevada Hospital Association. Thank you so much.
Thank you.
Will the next caller with the last 3 digits of 503 please slowly state and spell your name for the record? You'll have 2 minutes and you may begin.
Hello, Chair and committee members. My name is Chris Bosse. That's B-O-S-S-E for the record, representing Renown Health in Reno, Nevada. We appreciate Senator Lang and representatives from the Culinary Health Fund working with the industry to improve the bill and determine if there are unintended consequences that can be corrected in the bill language. We do, however, oppose both the bill as drafted and the conceptual language provided yesterday. While we've only had the conceptual language for less than 24 hours and we've not been able to determine all the impacts of the bill, our initial primary concerns are as follows. As an integrated delivery system, Renown Health provides value to its patients and those employer groups and payers we contract with by being able to provide high quality care in the most cost-effective setting, including this past year during the COVID pandemic, in the patient's home when appropriate. Excluding components of the delivery system we offer diminishes our ability to meet patients' needs. By connecting the components of the healthcare delivery system, we're able to coordinate care, hold components of the delivery system accountable to outcomes, and improve communication between the levels of care and the patient. SB 329 undermines components that nationally CMS has encouraged healthcare delivery systems to build through establishing accountable care organizations, which have demonstrated ability to improve quality and provide care most cost effectively. Finally, Section 8 in the most recent amended language voids elements of existing contracts where rates have been established based on the entire framework of a current contract. This places significant hardship on hospitals and healthcare delivery systems in Nevada who provided discounts based on a predicted number of patients. This will likely result in an unprecedented volume of contract renegotiations where prices will have to go up to sustain services in an environment of significant uncompensated costs related to government and uninsured care we provide. As stated previously, we oppose SB 329 and hope to work with Senator Lang and the Culinary Health Fund to address these concerns. Thank you.
All right, will the next caller with the last 3 digits of 900, please slowly state and spell your name for the record. You'll have 2 minutes and you may begin. Once again, caller with the last 3 digits of 900, please slowly state and spell your name for the record. You'll have 2 minutes and you may begin.
Hello, this is Dan Musgrove. I apologize for my technical difficulty, I guess because it's my second bite at the apple tonight. So I apologize, Madam Chair. Dan Musgrove, D-A-N, capital M-U-S-G-R-O-V-E, on behalf of the Valley Health System of Hospitals. We are in opposition to this bill. In the interest of time, I would just echo the comments of my colleagues from HCA as well as Renown. We absolutely want to work with the sponsor through the NHA. But the Valley Health System is 8 hospitals statewide and soon to be 9. And it is that system of care that prevents fragmentation and actually delivers better care at a better cost to both our insurer partners as well as, more importantly, our patients. And so we want the opportunity to try to rectify the bill as it is, but we stand in opposition. Thank you for the opportunity to testify this evening.
If there are any more callers who wish to testify in opposition to SB 329 and have just joined us, please press *9 now to enter the queue. Chair Ratty, at this time, no other callers are wishing to testify in opposition to SB 329.
Thank you. Let's go ahead and open testimony in neutral.
Certainly, Chair. Callers, if you want to testify in a neutral position for Senate Bill 329, please press *9 now to enter the queue. Once again, that is *9 now for a neutral testimony on SB 329.
Chair Ratty and members of the committee, this is Margot Chappell for the record with the Division of Public and Behavioral Health in the Department of Health and Human Services. We have reviewed the bill and there is some fiscal impact we wanted to report to you. The fiscal note should be sent tomorrow, hopefully. But because of the language in Section 1 that identifies proposed statute language where our offices would be responsible for setting up the website, collecting the data, and analyzing and reporting the data, we will need to add staff. So just wanted to go on the record to make you all aware. Thank you.
Thank you, Ms. Chappell. Yes, if we'd open up the phone line as well.
Thank you, Chair. Caller with the last 3 digits of 582, please slowly state and spell your name for the record. You'll have 2 minutes and you may begin.
Good evening, Chair Ratty and members of the committee. My name is Jaron Hildebrand, and I am the Executive Director of the Nevada State Medical Association, comprised of nearly 2,000 physician members statewide. However, we consider ourselves as a patient advocacy organization first and foremost. I'm here today in neutral with concerns on SB 329. To begin, I'd like to thank Senator Ratty Senator Lang for bringing all of us together for stakeholders, including the bill's supporters, so we could talk directly. Like folks have mentioned previously, we received this amendment late afternoon yesterday, and I'm still waiting on feedback from some of my membership. Generally, we favor transparency, and we fully share the concerns of the bill sponsor increasing costs in healthcare. Many of our practices have been crushed during this pandemic, and we know the residual effects from the COVID pandemic have yet to be seen in our small practices across the state. We do have some concerns with the reporting sections at the beginning of this bill. Most transactions in the state are not a concern, and it cannot be emphasized enough that the Attorney General already has the ability to intervene where there is a reason for concern. Increasing the thresholds for individual providers to a percentage of specialty markets and specifying a material change should trigger the reporting would reduce our concerns, including small joint ventures and management contracts would likely overwhelm the department and would not meet the intent of the reporting. We're still reviewing the second half of this bill and working fully to understand the anti-steering and the anti-tiered provisions will affect the market. We support competition in the market, and we believe patients should have access to high quality care. We simply do not want to take away contracting tools from our small providers when they are negotiating with large corporations. We are committed to working with the bill sponsor and supporters and look forward to reviewing a new draft of the bill when it's available. Again, thank you for your time, and I appreciate everyone's time and concerns. Thank you.
Thank you. Next caller.
Will the next caller with the last 3 digits of 080, please slowly state and spell your name for the record. You'll have 2 minutes and you may begin.
Thank you, Madam Chair and Committee, and thank you to Senator Lang as well for meeting with us, with the stakeholders. This is Susan Fisher, SUSAN-FISHER, with McDonald Carano, representing the Nevada State Society of Anesthesiologists. We are neutral with concerns for the same reasons that were expressed by Jared Hildebrand with an SMA. We've failed to see how the bill will help with patient-physician relationships and would like a better understanding of how, if a physician reports to one insurer what another insurer pays them for similar services, how does this actually help either the patient or the provider? So we do have some concerns. We are still analyzing the amendment and then also how this bill interacts with the AG's bill that is of a similar nature as well. So we're looking forward to seeing some additional language. Thank you.
Thank you.
Will the next caller with the last 3 digits of 836 please slowly state and spell your name for the record? You'll have 2 minutes and you may begin.
Thank you, Chair and members of the committee. For the record, my name is Jessica Ferrato, Jessica-Ferrato. Today on behalf of Nevada ACEP, the College of Emergency Physicians, we are here testifying in neutral on SB 329. Healthcare transparency is a priority for ACEP. We currently are reviewing the changes from the amendment and look forward to continuing to work with the sponsor and all stakeholders on the bill. Thank you.
Thank you.
Will the next caller with the last 3 digits of 175 please slowly state and spell your name for the record? You'll have 2 minutes and you may begin.
Chair Reddy and members of the committee, Lindsay Knox, Lindsay, Knox, KNOX, with McDonald Carano, representing the Nevada Orthopedic Society. We appreciate Senator Lang bringing this bill forward. Unfortunately, we have not had time to review the conceptual amendments, so we are neutral with concerns and echo the comments made by Mr. Hildebrand and Ms. Fisher. We look forward to participating in any working group Senator Lang organizes. Thank you.
And will the next caller with the last 3 digits of 523 also please slowly state and spell your name for the record? You'll have 2 minutes and you may begin.
Good evening, Chair Reddy and members of the committee. My name is Tom Clark. That's Tomclark. I'm here on behalf of the Nevada Association of Health Plans. We are the private insurance carriers that make up about 19% of the market here in Nevada. Thank you for the opportunity to provide my brief testimony in the neutral position on Senate Bill 329. We've had the pleasure of working with the sponsor, and that work has produced an amendment that gives the private carriers a comfort level that allows me to be in the neutral position. However, we do look forward to future meetings with Senator Lang and the other stakeholders as this bill makes its way through the legislative process. Thank you, Madam Chair.
Chair Reddy, at this time, there are no other callers wishing to give a neutral testimony for SB 329.
Thank you, BPS, for your support on that, and frankly, for you and your team for everything tonight and what's been a long day, I'm sure. All right, we'll go back to the sponsor and see if you have closing comments.
Where I just be really quick. I just too want to thank BPS and Chair Ratty and your committee for enduring a very, very long hearing and making sure that everyone felt like their bill was important. This bill is about consolidation and transparency, and I would not have been asked to carry this bill if there hadn't been some issues. So I think that we are more than happy, and we have been working with the stakeholders. We'll continue to work with the stakeholders and try and resolve the issues so that we can get this bill to work session. And I really appreciate your time.
Thank you, Senator Lang. And definitely sounds like there's some conversations to be had and some work to be done. I'll just caution all of the stakeholders involved that time is of the essence. And I heard some references to when we see a new copy of the bill. And I just want to be very clear that from a capacity standpoint, I don't anticipate that there will be mock-ups. So I'm going to need to ask everybody to do the best that they can working off of conceptual amendments. And then, of course, we always have the time between committee passage, should this bill pass, and the floor to look at a fully redrafted bill. But with that, thank you, everybody, for your participation. Lots of engagement. Committee, go team. We've had had another long one, and there's going to be another long one. So I just wanted to quickly, for my committee and for members of the public, say that on Thursday, we will be hearing 5 additional bills. Those will be SB 275, SB 376, SB 379, SB 391, and SB 397. For folks who are working on those bills, if you've got amendments, the earlier you can get them to us, the committee would greatly appreciate that. And we will not be having a work session. We won't have our full membership on Thursday. So on the following Tuesday, we will have the bills from the interim committee on pharmaceutical costs. So it will be a day dedicated to the issues of pharmaceutical costs. And I anticipate that we will have a significant work session on that day to get us caught up. So again, members, looks like we're going to have long meetings through the deadline. I appreciate you being so dedicated to the work of this committee. With that, BPS, if you could help us by opening it up to public comment, see if anybody has survived long enough to make it through to public comment.
Thank you, Chair. Callers, if you'd like to give public comment, please press *9 now to enter the queue. Chair, at this time, no callers have indicated that they wish to give public comment.
Thank you. And then one last thank you to Eric and Megan from our LCB staff, and Nicole, Norma, and Vicki, who are behind the scenes, making sure that this all gets handled and that we get minutes after the fact. And Senator Hardy, if you could just explain to us all, are you in a carnival game? That what's happening here?
Okay, you asked, so that is my son's masks that he has made and gives them to people. And so he's a professor in Atlanta, Georgia at Emory, and now he's famous because he gets masks for people.
All right, well, we'll call that public comment. All right, thanks so much, everybody. Have a great night.